and welcome everyone to the second day of our ACIP meeting. Today is June 23rd, and I'm pleased to call our ACIP meeting to order. I will now take roll calls for the members only, and as a reminder, please state your name, your affiliation, and whether you have any conflicts of interest. Today we will begin with Ms. Lynn Bata.
Good morning, Lynn Bata. I'm a public health nurse serving as the clinical immunization consultant at the Minnesota Department of Health, and I have no conflict.
Thank you. Dr. Bell. We'll come back. Oh, are you there?
Oh, sorry. I thought I Beth Bell, clinical professor, University of Washington. I have no conflicts.
Thank you. Ms. McNally. Ms. McNally?
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflict.
Thank you. Dr. Sineas.
Good morning, Dr. Sybil Sineas. I am an internist and pediatrician, associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Chen.
Good morning. Wilbur Chen, professor of medicine at the University of Maryland School of Medicine, also director of the University of Maryland Baltimore Travel Medicine Practice. My employing institution, the University of Maryland, received a grant from Emergent Biosolutions that supported work I conducted to develop a Shigella vaccine. This relationship with Emergent ended December 2021, approximately 6 months ago. Nonetheless, I make mention of this due to the potential perception of conflict of interest on vaccines in development by Emergent, which may be discussed today. There will be no votes on these respective vaccines today, and therefore I perceive that there's no real conflict of interest, but I wanted to make sure I mentioned these. Thank you.
Thank you very much, Dr. Chen. Let me see, scanning the list. Dr. Lair.
Good morning. This is Dr. Jamie Lair. I'm the owner of Cayuga Family Medicine, a private family practice in Ithaca, New York, and I have no conflicts of interest.
Thank you. Ms. Bata? Did I already call on you? I apologize. Dr. Sanchez.
Morning, I'm Pablo Sanchez. I'm professor of pediatrics at the Ohio State University College of Medicine. I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital in Columbus. I have no conflict. Thank you.
Thank you. Dr. Brooks.
Corporation. I have no conflicts.
Yeah, Dr. Brooks, we lost you in the beginning. Could you just restate your name?
Sorry. Dr. Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation in South Los Angeles, and I have no conflicts.
Thank you very much. Dr. Daly.
Good morning, Dr. Matt Daly. I'm senior investigator at Kaiser Permanente, Colorado, and associate professor of pediatrics, University of Colorado School of Medicine. I have no conflicts of interest. Thanks.
Thank you. Dr. Long.
This is Sarah Long. Good morning. I am a pediatric infectious disease physician and professor of pediatrics at Drexel University College of Medicine. I have no conflict.
Thank you, Dr. Long. Dr. Talbot.
Good morning. I am Kip Talbot. I'm an associate professor of medicine in the Division of Infectious Diseases. I do adult ID, and I have no conflicts.
Thank you. Dr. Cotton.
Good morning, Dr. Camille Cotton. I'm the clinical director of transplant and immunocompromised host infectious diseases at Massachusetts General Hospital and at Harvard Medical School. I have no conflicts. Thank you.
Thank you. Dr. Alt.
Good morning. My name is Kevin Alt. I'm a professor of obstetrics gynecology at the University of Kansas Medical Center in Kansas City, Kansas, and I have no conflicts.
Thank you. Dr. Paling.
Good morning. This is Kathy Paling. I am Professor of Pediatrics and Epidemiology and Prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you. And this is Grace Lee. I'm a Professor of Pediatrics at Stanford University School of Medicine, Associate Chief Medical Officer, Stanford Children's Health, and I have no conflicts. Thank you, everyone. We have quorum. We actually have a complete committee today. So next, we will plan to move on to agency updates. We're going to go a little bit out of order this morning, so just to warn my colleagues. I'm going to call on the Center for Medicare and Medicaid Services to see if there are any updates.
Good morning, this is Mary Beth Hant. Sorry, it took me a minute to get off mute and I'm trying to pull them up.
Apologies, I did not warn you. I was going to go out of order.
No worries, no worries. I always rely on CDC going first, which was a mistake. So I just have two minor updates. Okay, I'm ready. Sorry about that. So in our, I think the February meeting, I mentioned that CMS has established a policy of covering standalone vaccine counseling. And we issued guidance on that on May 12th of this year. And on June 8th, we actually announced new standalone vaccine counseling codes. So that is really my major update. The only other update I wanted to mention is just that we continue to provide updated information around COVID-19 vaccines after decisions are made by FDA and CDC. We issued a listserv announcement yesterday around the decision over the weekend to expand the vaccines to the youngest children. And so we will continue to update toolkits, websites, all the other materials that CMS releases whenever those decisions are made to keep them up to date. And that's my update. Thank you so much.
Thank you, Ms. Hance. Next, we will move, maybe I won't go totally crazy. I'll move to Food and Drug Administration, Dr. Fink.
Hi, good morning. Doran Fink on behalf of the U.S. Food and Drug Administration Office of Vaccines. I have two updates this morning. First, next week on Tuesday, June 28th, FDA will convene its Vaccines and Related Biological Products Advisory Committee to discuss potential updates to the strain composition of COVID-19 vaccines for use in the U.S. Available data continue to support that our current vaccines, which are based on the ancestral Wuhan strain of SARS-CoV-2, continue to offer protection against more severe COVID, especially when booster doses are administered as part of the vaccination regimen. However, circulating variants of SARS-CoV-2 are becoming increasingly antigenically distinct from the vaccine. And we do have the opportunity ahead of the fall and winter months when we expect there to be additional surges, or the potential for additional surges, and the potential for other emerging variants. We have the opportunity to improve the protection afforded by our vaccines by bringing their antigenic components more in line with the variants that are circulating and may emerge in the future. So that will be the basis of the discussion on Tuesday of next week. And I unfortunately will have to step away from the first part of this meeting as we prepare it at FDA for our VRPAC next week. And I will try to rejoin the ACIP meeting as soon as I can. The second update that I want to provide relates to the two votes yesterday on the recently approved Priorix MMR vaccine and Vaxneuvance 15-valent pneumococcal vaccine. which was approved for use in pediatric populations. So these approvals were the result of a tremendous amount of work by the FDA review staff, especially considering the complexity of the applications, which both included multiple studies involving many thousands of study participants, and also especially considering the review resources that we currently have at our disposal and the other competing priorities. And I just want to call out our review staff who worked on these two files. The fact that we were able to get these approvals done within the statutory timelines just speaks to the tremendous dedication and sacrifice that our FDA review staff continue to make during these times. Thank you.
Thank you, Dr. Fink. We really appreciate the timeliness with which your team has been able to review and authorize and approve all of these additional vaccines. We seem to be adding work without adding staff, and that is a huge challenge, and we recognize just how challenging that is for all of us at many of the agencies, as well as many of us on the front line. So really appreciate that. Next, we'll move to Health Resources Services Administration, HRSA.
Morning, this is Mayor Rubin. Thank you for this opportunity to provide an update for the Division of Injury Compensation Programs. The National Vaccine Injury Compensation Program, VICP, continues to process an increased number of claims. In fiscal year 2022, as of June 1, petitioners filed 601 claims with VICP, and nearly $120 million was awarded to petitioners, including their attorneys' fees and costs. In addition, as of June 6, 2022, the VICP had a backlog of 1,439 claims alleging vaccine injury awaiting review. As for the Countermeasures Injury Compensation Program, as of June 1, 2022, 8,439 claims alleging injuries or deaths from COVID-19 countermeasures have been filed with the Countermeasures Injury Compensation Program, CICP, including 5,449 claims alleging injuries from COVID-19 vaccines. 31 claims have been denied compensation. One claim has been determined medically eligible for compensation. However, compensation has not been awarded yet and is pending a review of eligible expenses. More information can be found in both the VICP and the CICP website. That ends my update.
Thank you very much, Dr. Rubin. We'll move next to Indian Health Service.
Good morning. This is Dr. Matthew Clark, and I appreciate the opportunity. The Indian Health Service continues to confront the SARS-CoV-2 pandemic and its impact on population health and routine immunization efforts. Since September 2020, the IHS COVID Vaccine Task Force has coordinated both the distribution and administration of COVID vaccines agency-wide, including at federal direct care facilities and the tribal health programs and urban Indian organizations that receive vaccines through the IHS jurisdiction. Collaborating with our federal, tribal, and urban Indian organization partners, the IHS has prioritized equitable access to COVID vaccines throughout Indian country. To date, participating federal, tribal, and urban facilities within the IHS jurisdiction have administered over 2.2 million COVID vaccines. According to current CDC tracker data, among the estimated 2.1 million people served at IHS facilities, including American Indian and Alaska Native individuals, healthcare workers, and community members, approximately 42% are fully vaccinated, and 32% of those fully vaccinated have received a booster dose, as we continue to mitigate the impact of serious COVID illness in Indian country. Following recent regulatory actions by the FDA and CDC, earlier this week, the IHS rapidly communicated information regarding COVID vaccines for children under 5 years of age. We anticipate that a majority of children in this age group will be vaccinated in their IHS medical home, and federal, tribal, and urban facilities are now actively engaged in implementation. Across our 3 surveillance systems to date, IHS COVID vaccine safety monitoring has demonstrated a reassuring safety profile consistent with other national vaccine safety surveillance systems. And meanwhile, the IHS routinely collaborates with the CDC and engages with tribal leaders to support vaccine confidence among the American Indian and Alaska Native service population. Lastly, the IHS immunization program has leveraged COVID-19 vaccination strategies to efficiently implement new and expanded ACIP eligibility recommendations within our service population for adult pneumococcal, zoster, and hepatitis B vaccines. The immunization program developed a resource and clinical guidance document and conducted training to support implementing pneumococcal and zoster recommendations in the field. We look forward to continued collaboration with our tribal, urban, and federal partners to ensure access to safe and effective vaccines across the age spectrum for American Indians and Alaska Natives served by the Indian Health Service. Thank you.
Thank you. Thank you very much, Dr. Clark. Next, we'll move to Dr. Eigel. Sorry, National Institutes of Health.
Good morning, John Beigel from the National Institute of Health. So not surprisingly, the NIH continues to invest in multiple COVID vaccine efforts. In March, NIH began a study using both prototype and variant vaccines to try to inform on how best to cover the COVID-19 antigenic landscape. And that's both to cover the variants we know and the variants that may emerge in the ensuing months. That studies 3 different vaccine manufacturers, Moderna, Pfizer, and Sanofi, with 5 to 6 strategies, 5 for Moderna, 6 for Pfizer, of using the different variant vaccines. And the goal is to both understand the immediate, how you cover things now, but also how we sort of modify the immune response in the future. So I think that will contribute a lot of interesting data. The NIH continues to evaluate work on allergic reactions to COVID-19 vaccines. There's just a new study started at the clinical center, the NIH Clinical Center in Bethesda, to evaluate people that have had allergic reactions from COVID-19 mRNA vaccines, and it's a very detailed analysis to try to understand the etiology of some of these reactions. Lastly, for COVID, the NIH has published on preprint an interesting article looking at maternal vaccinations, and it does really detailed immunology and looking at transplacental antibodies and antibodies in the newborn and what the kinetics there are. As far as non-COVID work, the NIH launched a clinical trial with 3 mRNA HIV vaccines. The mRNA platform has been incredibly valuable for COVID-19 and with robust immune responses, and it is hoped that that will enable diseases such as HIV to be treated with vaccines. So we're very excited about this vaccine, and this started through the HVT, the HIV Vaccine Trials Network. There's a new vaccine for the Eastern equine, Western equine, and Venezuelan encephalitis viruses. It's a trivalent virus-like particle that has been developed at the Vaccine Research Center at the NIH, and that has been shown safe and generated robust immune responses. Right now, those viruses cause diseases with often fatal encephalitis, and have an effective vaccine that we think is critical. Lastly, the NIH launched a new clinical trial on Epstein-Barr vaccine. Epstein-Barr, as most people know, causes infectious mononucleosis, but also associated with certain cancers and autoimmune diseases. This vaccine uses a novel ferritin nanoparticle vaccine, and hopefully will enable this field to move forward. There's been limited work on Epstein-Barr vaccines in more than a decade, and we think that this is an interesting way to move the field forward. So details for all this work will be provided in written summary to the ACIP, and that concludes the updates from the National Institute.
Thank you so so much, Dr. Beigel. It sounds like you're going to keep us very busy for a long period of time, so thank you. Next, we have the Office of Infectious Diseases and HIV/AIDS Policy.
Well, good morning. Thank you very much, Dr. Lee. I'm pleased to announce that earlier this month, the Assistant Secretary of Health named Kay Hayes, MPA, as the Deputy Assistant Secretary for Infectious Disease and Director of the Office of Infectious Disease and HIV/AIDS Policy. Ms. Hayes has been the Acting Director of OIDP for the last 2 years, and she comes to the position with over 25 years of experience in OASH. We also held the first in-person meeting since the pandemic started of the National Vaccine Advisory Committee on June 15 and 16 in Washington, D.C. The Assistant Secretary for Health, Admiral Rachel Levine, highlighted 2 issues of concern, immunization equity and health worker burnout, and gave 2 new charges for NVAC. Charge number 1 is on innovation, and the charge reads, by September 2023, the group is to develop recommendations to spur innovations in vaccine development and related technologies. Charge number 2 is on vaccine safety, and by June 2023, she charged the group to review vaccine safety systems and vaccine safety strategies to determine what should be maintained and what new strategies are indicated. The next NVAC meeting will be on September 22 and 23. The vaccine's federal implementation plan is currently under development, and we're near the finish line. The implementation plan is a complementary document to the National Vaccine Strategic Plan, and the target audience is the federal agencies. OIDP has incorporated public comments received from the Federal Register notice into the draft implementation plan and will be reviewed by the Interagency Vaccine Work Group for their review before going through the interdepartmental and HHS clearance. We expect the implementation plan to be released by late summer. And lastly, the National Vaccine Program is collaborating with CDC and the Office of Disease Prevention and Health Promotion in OASH on converting developmental immunization objectives to core measures in Healthy People 2030. The Healthy People 2030 sets data-driven national objectives to improve health and well-being over the next decade. The immunization objectives are aimed to improve adult immunization across the lifespan and increasing the number of pregnant women who receive the Tdap vaccine during pregnancy. And we're looking forward to this conversion of the developmental objectives into core objectives in Healthy People 2030. That concludes my updates for OIDP. Thank you very much, Dr. Lee.
Thank you so much, Dr. Kim. Those were excellent updates. And next, we'll go to the Centers for Disease Control and Prevention.
Good morning. Thank you again. Let me begin by saying that how honored I am to be back here with you all as the new director of the CDC's National Center for Immunizations and Respiratory Diseases. Let me take a few moments to update you on some quick issues. So, as some of you may know, and for those who do not, I'm pleased to announce that in early May, Dr. Georgina Peacock accepted the permanent position as director of the NCIRD's Immunization Services Division, ISD. Dr. Peacock joined the team almost 10 months ago, serving as the acting ISD director, and brought valuable and relevant experience, most recently from her leadership roles in the COVID-19 Response Vaccine Task Force, the Georgia Department of Public Health, and the CDC's Division of Human Development and Disability within the National Center for Birth Defects and Developmental Disorders. We are very thrilled to have Dr. Peacock as part of our leadership team. She will apply her wide-ranging expertise and experience in implementing population health programs that face challenges and reimagining the pillars of preventive health care and pandemic response, our domestic immunization portfolio, and emergency capability. I want to thank everyone here who worked on the important issues and votes yesterday. Our regularly scheduled ACIP meetings are essential to the work we must do to revitalize and prioritize routine immunization for all ages. Despite signs that the pandemic has clearly disrupted childhood immunizations, routine vaccine coverage remains high, and we look forward to working with the broader public health community to recover ground that was lost during the pandemic. This work includes gearing up for the upcoming influenza season. We are well positioned with vaccines that can protect people from influenza's most serious consequences. The preferential recommendation vote that will continue to help us make certain that older adults get influenza vaccines that best protect them. It may also assist our efforts to address health disparities by making these vaccines more available to racial and ethnic minority groups. We look forward to working with all our partners on the implementation challenges and considerations and removing these as quickly as possible. A few words on outbreaks. Meningococcal disease, as many of you know, in Florida is a major issue for us at this time. There's an ongoing deadly meningococcal disease outbreak in Florida, spreading primarily among gay and bisexual men. It's one of the worst outbreaks of meningococcal disease among gay and bisexual men in the U.S. in the history of the U.S. At least 24 cases and 6 deaths among gay and bisexual men have been reported. CDC is currently recommending that gay, bisexual, and other men who have sex with men get a men ACWY vaccine if they live in Florida, or talk with their healthcare provider about getting vaccinated if they are traveling to Florida. We are also emphasizing the importance of routine men ACWY vaccination for individuals with HIV. With regard to monkeypox, the CDC continues to track multiple cases of monkeypox that have been reported in several countries that don't normally report monkeypox. This includes the United States, and we'll hear more about that later in our presentation today. The agency is also closely watching the World Health Organization International Health Regulation Emergency Committee meeting today to determine whether the multi-country monkeypox outbreak constitutes a public health emergency of international concern. The CDC will provide frequent updates as we learn more. Thank you all for your time this morning, and I look forward to hearing the excellent presentations and discussion today.
Thank you so much, Dr. Romero. I just want to take a moment to thank all of our colleagues from the federal agencies for their service and dedication and for their continued focus on improving the health of our populations. I also want to just take a moment to highlight to the public that people working in our federal agencies have really been working around the clock to protect the public, and it seems like there is no end to the series of crises that are coming our way. And so we really need to be mindful of burnout in the public health sector, much as we are very much concerned about burnout amongst our healthcare providers and staff. So I want to say that we continue to thank people, but it's just simply not enough. And I hope that our systems will continue to be supported to ensure that the workforce is able to function because this pace, in my perspective, continues to be unsustainable. But that said, we do have to move on to today's business. I just wanted to take a moment to recognize everyone's work as we go from one emergency to another, and hope that we can continue to stick together and work as a team to make sure that we're protecting the public. We'll move on to the first session for today. Dr. Matt Daly will provide an introduction and overview of our COVID-19 vaccine session for the morning. So Dr. Daly.
Yeah, thank you so much. So I am presenting today to introduce the session, and I'm presenting on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. So this figure shows trends in the number of COVID-19 cases in the U.S. among persons of all ages, and just to highlight that there have been more than 85 million reported cases in the U.S. since the start of the pandemic, and currently our 7-day average is more than 100,000 cases per day. Next slide, please. And then this figure shows daily trends in COVID-19 deaths in the United States, and 2 points to emphasize here. There have been over 1 million deaths from COVID-19 since the beginning of the pandemic, and currently the 7-day average is 266 deaths per day. Next slide, please. And then this is a figure we've shown before, but wanted to show again. This figure shows the rate of COVID-19 deaths by vaccination status in people ages 5 and over in the United States for the 12 months from April 2021 to April 2022, with rates of death in unvaccinated in the black line, and then rates of death among those vaccinated with at least the primary series in the blue line. And this is one of the stronger pieces of evidence we can show to emphasize the fact that COVID-19 vaccination is effective at preventing death from COVID-19. Unvaccinated persons have 10 times the risk of dying from COVID-19 compared to people vaccinated with at least the primary series. Next slide, please. So this is a transition. This is showing vaccination coverage. So this is the percentage of children and adolescents who've received at least one dose of COVID-19 vaccine, with the green line being 12 to 17-year-olds and the blue line being 5 to 11-year-olds. And as you can see, 69.7% of the 12 to 17-year-olds have received at least one dose, and 36.2% of 5 to 11-year-olds have received at least one dose. And what this translates to is 7.5 million of the 12 to 17-year-olds and 18 million of the 5 to 11-year-olds who have yet to receive any COVID-19 vaccination. And this is just a stark reminder of all of the work that we need to continue to do to increase vaccination coverage. Next slide, please. So current recommendations for COVID-19 vaccines, as the audience is well aware, currently only Pfizer-BioNTech vaccine is authorized by FDA and recommended by CDC for use in children 5 to 17 years of age. This brings us to the focus of our session today. Next slide, please. So as an update, the FDA authorized Moderna COVID-19 vaccine for children 6 through 17 years of age. This was under emergency use authorization on June 16th of 2022. Just to be explicit about that recommendation, it's a 2-dose Moderna COVID-19 vaccine primary series for administration in individuals 6 through 17 years of age. In addition, authorized was a 3rd primary series dose among individuals ages 6 through 17 years of age with certain kinds of immunocompromise. Next slide, please. So just to provide an update on ACIP COVID-19 vaccines work group, since we met last week, June 18th, the recommendations were as follows. A 2-dose Moderna COVID-19 vaccine series of 25 micrograms was recommended for children 6 months through 5 years of age under emergency use as issued by the FDA. And again, this is 2 doses, 25 micrograms, 4 weeks apart between doses 1 and 2. In addition, last Saturday, ACIP voted to recommend 3-dose Pfizer-BioNTech COVID-19 vaccine series. This is 3 micrograms each. That was recommended for children 6 months through 4 years of age under an EUA issued by the FDA. So specifically, this is 3 doses, 3 micrograms each, 3 to 8 weeks between doses 1 and 2, and then 8 weeks or more between doses 2 and 3. Next slide, please. Moving to our agenda for today. First, we're going to hear from Dr. Seda at the CDC, who's going to review burden, prevalence, and trends in long-term sequelae for SARS-CoV-2. After that, we'll hear from Dr. Shimabukuro from the CDC, who will provide updates on safety of COVID-19 vaccines in children and adolescents. Following Dr. Shimabukuro, we'll hear from Dr. Talbot, who is an ACIP member and the chair of the vaccine safety technical subgroup, and she'll provide the VAST assessment of safety. Following this, we'll hear from Dr. Doss from Moderna, who will present on the safety and immunogenicity of Moderna 2-dose primary series in children 6 through 17 years of age. Following Dr. Doss, we'll hear from Dr. Oliver, who will present the evidence to recommendations framework for Moderna COVID-19 vaccine in children and adolescents aged 6 through 17 years of age. Following Dr. Oliver, we'll hear public comment. Following public comment, there will be a vote on the use of Moderna COVID-19 vaccine in children and adolescents ages 6 through 17 years of age. Next slide, please. My sincere thanks to the ACIP COVID-19 vaccines work group, who spent countless hours preparing for this and other meetings and other decisions. This includes ACIP members, ex officio and government members, liaisons, consultants, and the outstanding leadership of our CDC leads. Next slide, please. And then a large number of CDC participants, and I'd echo Dr. Lee's comments from a few minutes ago that these are individuals who put in an extraordinary amount of effort to best prepare us to help make these decisions today. Next slide, please. Thank you. I turn it back to you, Dr. Lee.
Thank you so much, Dr. Daly. And I believe we'll move to the next presentation on burden, prevalence, and trends of long-term sequelae of SARS-CoV-2 infection. Dr. Seda, the floor is yours.
Great. Thank you very much for the opportunity to present on this. I'm going to focus this presentation on pediatric population, but also mention some for adults. Next slide, please. To begin this discussion, I first want to address the variety of terminology that's in use. Long COVID is a term that's commonly used by patients who experience these problems. Similar terms are long hauler or long haul COVID. CDC uses post-COVID conditions. This is similar to the WHO. NIH uses the term post-acute sequelae of SARS-CoV-2 infection or PASC. The variety of terms really does reflect that we're still learning a lot about the longer-term consequences of SARS-CoV-2 infection. And while there might be minor differences in what is meant by each of these terms, they're often used interchangeably. Next slide. The post-COVID conditions refers to a wide range of physical and mental health consequences present 4 or more weeks after SARS-CoV-2 infection. These conditions can occur for patients with severe disease and also for patients who had mild or asymptomatic acute infection. This slide is presenting a general framework that describes the variety of these conditions. It's important to remember that these groups are not mutually exclusive. On the left are conditions that can occur as a result of any severe illness, hospitalization, or treatment, such as post-intensive care syndrome. And then on the right, we have processes that are likely more specific to SARS-CoV-2 infection. These are system-specific effects that could include new or newly diagnosed or identified neurological conditions, kidney damage or failure, diabetes, cardiovascular damage, or skin conditions. And then also symptoms that may have an unclear pathology. It can involve a range of problems that can last for months after the acute infection, or can even appear weeks or months after the acute phase is resolved. This unexplained group has features that are similar to NECSF, dysautonomia, POTS, and other post-infectious syndromes. Included in this group are also ongoing symptoms following MIS-C. Next slide. There are multiple mechanisms proposed for post-COVID conditions. As depicted in this graphic, many people who experience acute COVID go on to make a full recovery. Others may experience long COVID. We're still understanding some of the risk factors, but these seem to include those who are predispose people to more severe COVID, such as increased age, underlying medical conditions, and vaccination status. Post-COVID conditions may be explained by viral antigen persistence, systematic or tissue-specific inflammation, autoimmunity, microvascular dysfunction, or SARS-CoV-2 specific immune response. And it's unknown whether or not these mechanisms differ among children. Next slide. This slide lists the most commonly reported symptoms for post-COVID conditions. The ones noted in bold blue are symptoms that are more commonly reported by children. So these include fatigue, insomnia, chest pain, headache, and lightheadedness. Next slide. There's been a wide range of reported prevalence of post-COVID conditions among adults. Based on self-report data using a mobile app, 13% of individuals with incident COVID-19 followed up prospectively for symptoms reported symptoms ongoing at 1 month, and 2.5% reported ongoing symptoms at 3 months. When we use electronic health data among adults who are not hospitalized for COVID-19, 7.7% had one or more of the 10 common post-COVID conditions. And the severity of acute COVID-19 illness is also associated with the occurrence of at least one symptom at 6 months. Among patients from the VA, non-hospitalized patients had a lower frequency of post-COVID conditions compared to those hospitalized, and patients who were in the ICU for COVID had the highest occurrence. Next slide. Sorry, I lost my spot there. Most patients do report that the acute, most patients do recover from the acute illness within 4 weeks. This is part of the reason why CDC considers illness persisting beyond 4 weeks as warranting that initial clinical evaluation and supportive care. Highlighted in this figure from the UK Coronavirus Infection Survey, the proportion that report ongoing symptoms continues to decrease from the 4 to 12 weeks, and then improvement slows around 12 weeks. This curve is shown for both men and women. When stratified by sex, the pattern is the same, although a higher proportion of women report symptoms compared to men at each time point. Next slide. Children really do present a unique challenge in assessing post-COVID conditions. Younger children particularly may have difficulty verbalizing symptoms and may have developmentally different understanding of time, making it difficult to tease apart frequency, chronicity, and other details of their symptoms. Symptoms may also present in different ways with different children, and there's not one specific symptom or even a cluster that is exclusive to long COVID. An assessment of these conditions may also be dependent on what is expected at different developmental milestones. For example, sleep cycle changes might be perceived as developmentally expected, especially among very young children. And picky eating could be due to a loss of taste or smell, or it could be because children are often picky eaters. There are also numerous limitations in the current research for post-COVID conditions among children, including varying time points from infection for the assessment, lack of control groups, and a small sample size for many reports. Next slide. Similar to adults, the prevalence of post-COVID conditions can vary on the setting and methods used. Symptoms lasting for 4 weeks or longer from infection are common, with headaches and respiratory symptoms reported by about 7%, sleep disorders by 8%, fatigue by 9%, and mood disorders by about 6% of children who had COVID-19. Next slide. So this is showing results of non-hospitalized children who had mild or acute infections. These are from a survey of children in the UK. And we have the percent reporting a positive SARS-CoV-2 test ranged from 20% in those 5 to 11 years old to 30% in those 11 to 16. Among those who had a positive test, 1 to 7% had ongoing symptoms at 12 weeks, and then symptoms increasing in the older age group. Approximately 4% in the oldest age group had symptoms that impacted their activities of daily living for 12 weeks or longer. Next slide. This is a prospective cohort study that highlights the risk factors and symptoms experienced by children who are hospitalized with COVID-19. The figure on the left reports the risk factors for post-COVID conditions. Compared to the youngest children, those ages 6 to 11 years and those 12 to 18 years had the highest risk for post-COVID conditions. Children with a history of allergic diseases also were more likely to report post-COVID conditions compared to those without the history of allergies. And then the figure on the right highlights that many of the common symptoms experienced by adults are also experienced by children, with fatigue, the green line on top, being the most common, followed by sleep problems. And similar to adults, the duration of symptoms decreases over time. Next slide. These next two slides present results from a study we recently published using PCORnet data. This is a distributed research network with 42 participating healthcare systems and 2 health plans. We compared patients who had a COVID-19 test between March and December of 2020 and then received medical care for any reason in the 31 to 150 days after they were tested. Children with a positive SARS-CoV-2 test were more likely to receive a diagnosis for a new condition or symptom in the 5 months after their acute infection compared to those who received a negative test. This figure presents unadjusted prevalence ratios for children who tested positive compared to those who tested negative. They're broken down by severity of illness, with the non-hospitalized in gray and then the hospitalized in orange. Fatigue and shortness of breath were more common among children testing positive, particularly those hospitalized. Next slide. We also looked at several conditions that were more likely to be newly diagnosed in children testing positive compared to those testing negative. Of the 4 highlighted here, type 2 diabetes was more common among children hospitalized with COVID-19. Next slide. As highlighted in the previous slide, children and adolescents with COVID-19 appear to be at a higher risk for newly diagnosed diabetes. We investigated this further using electronic health data sources and examined newly diagnosed diabetes in children and adolescents. We compared children and adolescents with COVID-19 to those without COVID-19 during the same time period, as well as to a group with acute respiratory illnesses in the pre-pandemic period. Children and adolescents with COVID-19 were 2.7 times more likely to be newly diagnosed with any type of diabetes in the months following infection compared to those without COVID-19 or those diagnosed with other respiratory infections prior to the pandemic. And similar results have been observed in the adult population. Next slide. This slide presents some unpublished analysis looking at the incidence of 12 conditions and 8 symptoms among close to 2 million children with and without COVID-19 in a closed payer claims data set. Here we're highlighting the incidence of potential post-COVID conditions that were significant for this group. We found that there were 9 post-COVID conditions and 4 post-COVID symptoms, most of which were rare or uncommon, uncommon, but they were more likely to occur among children with COVID-19 compared to those without COVID-19. Next slide. And finally, children with MIS-C also appear to have a higher risk of ongoing symptoms following MIS-C. Continued difficulties are reported by 35% of the children and 21% of the children's parents at 6 months. The figure here illustrates the number of symptoms impacted by children, the white portion, and adolescents, the gray portion, including inflammation, gastrointestinal, renal, cardiac, and neurological systems. The number of systems affected at baseline is greater than those at 6 weeks, which is the middle circle, or by 6 months. But a number of children and adolescents still have impact at 6 months. Next slide. Most of the studies that have looked at post-COVID conditions occurring after vaccine breakthrough have focused on adults. There have been 2 published to date that we know about that included adolescents. These found that post-COVID conditions and symptoms were less likely to occur in 12 to 20 weeks after infection among those previously vaccinated compared to the unvaccinated. We don't know the exact mechanism that vaccines may prevent long COVID symptoms, but we do know that vaccines can prevent post-COVID conditions by preventing infection. Next slide. So in summary, post-COVID conditions do occur among children and adolescents with COVID-19, regardless of acute illness severity, but appear to occur at higher frequency among those who are hospitalized and adolescents. A number of questions remain, including what is the frequency, severity, and duration of post-COVID conditions, what groups might be disproportionately impacted, and whether these associations with different SARS-CoV-2 variants changes. And finally, how post-COVID conditions may impact children and adolescents' daily activities and participating in school is important. Next slide. Thank you. This concludes our presentation.
Thank you very much for that presentation. This presentation is now open for questions. Dr. Lair.
Thank you very much for this presentation. It's very useful and good information. Could we please go to slide 6? There is a large number of people who had symptoms after being hospitalized and in the ICU. Do we have a comparison group to know how many people in the ICU who did not have COVID might have these symptoms? Is it 20% or 15%? Thank you.
Thank you. That's a good question. I would have to go back and look at this specific study to get that exact estimate for this one. I will say that on the slides where we presented results from the Cohort analysis, we also included adults in that analysis. There we did compare to those who were mechanically ventilated for a number of the conditions and symptoms, and did see an increase still among the mechanically ventilated for many of these conditions among adults compared to those who did not test positive for SARS-CoV-2.
Thank you. Dr. Brooks?
Yes, excellent presentation. I think the odds ratio of 2.66 for new diagnosis of diabetes is just fascinating and concerning, I might add. The very last slide, you stated that there is not information on groups disproportionately affected, but I'm assuming that you do have race and ethnicity data on a lot of the patients or the studies that you presented. So is there information on race and ethnicity in terms of the effects of long COVID in those populations?
That's an excellent question. And we are looking at publishing more detailed results focused specifically on race, ethnicity. Many of these electronic data sources that we've published on so far don't have missing some of the components for race, ethnicity, which is part of why we haven't published that yet, but we are actively working on that.
All right, thank you.
Thank you. Dr. Daly?
Yeah, thanks so much, Dr. Snida. What do we know about vaccination among those who've already been infected with respect to the trajectory of post-COVID conditions? And I bring this up because there's certainly going to be a number of kids under 5 and then kids 5 through 17 who were infected prior to vaccination and may or may not have symptoms of post-COVID conditions at the time of vaccination. Thank you.
Yes, thank you. That is a question, right? Looking at the vaccination prior to infection for post-COVID conditions, and also infection, those with post-COVID conditions, and then vaccinated, and how vaccine impacts post-COVID conditions. there hasn't been as much published on looking at among people who have been infected, reporting symptoms, and then vaccinated. Some individuals, we have one study based on a survey where individuals did report that their symptoms improved after vaccination. There is a recently published article from the UK from their coronavirus community survey that did look at this, and they did not, I have to look at the exact numbers, but what I remember from that article is that they did not find a strong association of reduction in post-COVID conditions among those who were vaccinated after infection compared to those who remained unvaccinated.
Thank you. Dr. Sanchez?
Thank you. This was very comprehensive, and thank you. I had a couple of questions. First of all, you mentioned that there's no information on the new variants, but my understanding, at least there's been some recent reports that post-COVID symptomatology has been less with the new variants. And I was wondering, have you been able to look at a timeline of when the post-COVID symptomatology was reported with more recent changes in the new variants?
Yeah, we have not yet had a chance to look at that in our data, but that is important. When there are a number of factors related to that also, and now that as we're moving further out in this pandemic, individuals are also more likely to report reinfections, how that might impact post-COVID conditions. We still need to understand and look at along with the effect of vaccination.
And my second question, so there's been these reports, and I almost hate to mention them, of post-COVID type symptomatology after vaccination. If you'd like to comment on that, I would appreciate it. And are those individuals who actually have been infected? Any comment on that?
Heard those reports, but it seems like it's relatively.
I'm sorry, I couldn't hear you.
I said, yeah, sorry. I will just actually, if there are others from CDC on the line who can respond more to any adverse vaccine reporting, please feel free to weigh in. We have gotten these reports off and on, but we haven't seen anything specific based only on vaccination without any evidence of infection.
Hi, this is Dr. Shigella Vaccine from the Immunization Safety Office. Can you hear me?
Yeah, please go ahead.
So I think with respect to reports of conditions which have been described, we are aware of reports of people experiencing debilitating and long-lasting health problems after COVID-19 vaccination. In some cases, the clinical presentation of people suffering these health problems is variable and no specific medical cause for the symptoms have been found. We understand that illness is always disruptive and stressful, especially so under these circumstances. And we acknowledge that these health problems have substantially impacted the quality of life for these people and have also affected those around them. And we wish for improvement and recovery, and we'll continue to monitor the safety of these vaccines and work with partners to try to better understand these types of adverse events, and also to understand the impact of disease in the development of these adverse events.
Thank you, Dr. We'll move on to Dr. Paley.
Good morning. Thank you for a great presentation. It was very convincing that COVID-19 in children is not a benign illness, and that many children are suffering long consequences. I too, like Dr. Brooks, was really impressed with the test positive, test negative studies showing in the subsequent 5 months there's an increased risk of diabetes mellitus, a new diagnosis of diabetes mellitus among those that have been hospitalized, and then that was also found in the claims data. I wanted to look, if you could put the slide on the medical claims, because after COVID-19, I thought that was really important. I believe you showed symptoms as well as conditions. Myocarditis and pulmonary embolism were two that struck me. Also, what struck me was the MISC, that 35% of children report having symptoms 6 months later. And so this is really, thank you, this has been very helpful in understanding the long impacts and that COVID-19 is not benign in many children. Thank you.
Thank you, Dr. Paling. Could you highlight the slide you were pointing to? Do you know what number that was?
I have to look up what number that is. I think it is slide 16. No, slide 15. If you could put slide 15 up.
Thank you. Any additional questions? I'm just going to make a brief comment before we move on to the next section. You know, I'm really appreciative that CDC is beginning their work to understand what I'm concerned may be a huge public health burden due to past or due to long-term complications of the COVID-19 infection. So I feel like we've been very focused on the acute period, and I think we have a lot more to learn about the chronic burden of this condition. Also wanted to just acknowledge that NIH has initiated what's called the Recover NIH Initiative, where they're both following cohorts over time and understanding what the natural history is of long haul COVID, as well as, and I'm actually in full disclosure, part of the NIH real world data EHR cohort, where we're trying to understand and better characterize what PASC is in order to improve detection of PASC, understand risk factors, and think about treatment and prevention in children, and hope that we can again better characterize and understand what we need to do to address this emerging public health burden. So hopefully more to come, and really appreciate the great summary of the data that we have to date, but much more is on the way. So I don't see any other hands raised. So why don't we go on to the next session, which is Dr. Tom Shimabukuro with updates on safety of COVID-19 vaccines in children and adolescents.
Thank you. Next slide, please. So today I'll cover background on classic myocarditis and myocarditis associated with mRNA COVID-19 vaccination. I'm giving an update on myocarditis following mRNA COVID-19 vaccination with a focus on children ages 5 to 17 years, which will include findings from the Vaccine Adverse Event Reporting System and the Vaccine Safety Data Link. And then finally touch on comparative risk from myocarditis between the two mRNA COVID-19 vaccines. Next slide. So with respect to classic myocarditis in children, there's usually an infectious cause, typically viral or presumed to be viral, although infection with the pathogen is frequently not identified. It can be due to direct microbial infection of myocardial cells and our ongoing inflammatory response with or without clearance of the pathogen. Rare causes include autoimmune hypersensitivity and giant cell myocarditis. Incidence in males is greater than females starting after age 5 years. Previously unrecognized myocarditis was identified as a cause of death in 8% of cases of sudden death, sudden unexplained death in 1 to 17-year-olds and 9% of sudden death in athletes, according to a couple of studies. And as I mentioned, it's not uncommon to it is common to not identify a pathogen or possible infectious etiology for myocarditis. In some case series, less than half of the time a specific infectious cause was identified. Next slide. So this is a slide that has been previously presented at ACIP by Dr. Matt Oster, showing incidence of myocarditis in children on the left and then adults on the right. So you see in children, with the exception of very early in life when there may be genetic or other medical conditions playing a role, incidence is fairly low in early childhood and then begins to increase when children enter adolescence. And if you shift to the right-hand side of the slide, you see that incidence peaks in adolescence and then gradually decreases with age. Most cases are male, but that male to female predominance tends to even out in about middle age. Next slide. So this is a table showing characteristics of myocarditis associated with mRNA COVID-19 vaccination versus viral myocarditis. So for vaccine-associated myocarditis, the inciting exposure is mRNA COVID-19 vaccination with a risk for after dose 2 greater than dose 1. For viral myocarditis, it's viral illness, which is often can be asymptomatic. For vaccine-associated myocarditis, most cases have been in adolescents and young adults, with more cases in males compared to females. For viral myocarditis, there are more incidences higher in males compared to females and peaks in adolescents and then gradually declines. For vaccine-associated myocarditis, symptom onset has been observed within a few days after vaccination, with most cases occurring within a week. For viral myocarditis, it's typically 1 to 4 weeks after viral illness. The next characteristics get at severity of disease, and for vaccine-associated myocarditis is based on a large review, surveillance review of VAERS reports. But generally, vaccine-associated myocarditis has been relatively clinically mild when compared to viral myocarditis, which can be severe. Next slide. I'll move on to data from the Vaccine Adverse Event Reporting System, which is the national spontaneous or passive surveillance system that's co-managed by CDC and FDA. Next slide. VAERS accepts reports from everyone, regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. The key limitation of VAERS is that as a passive surveillance system, we generally cannot determine cause and effect from VAERS data alone. Next slide. This is a flow diagram showing reports to VAERS of myocarditis after Pfizer vaccination among children ages 5 to 17 years. Through the surveillance period, which was through May 26, 2022, there have been 972 preliminary reports of myocarditis identified. 214 remain under review. 123 did not meet case definition, and that leaves us with 635 reports verified to meet the CDC case definition. Put that number into context, there have been 54.8 million total Pfizer doses administered to children ages 5 to 17 in the United States during that surveillance period. Next slide. This is a figure showing time to symptom onset from vaccination, demonstrating this clustering of symptom onset within several days of vaccination, with the overwhelming majority of these case reports in VAERS having onset within a week of vaccination. Next slide. The table showing reporting rates of myocarditis per million doses administered after mRNA COVID-19 vaccination in the days 0 to 7 and 8 to 21 post-vaccination. The first takeaway from this is you see these peach shaded cells. That's where the observed reporting rate to VAERS exceeds the expected background incidence. And you'll notice that similar to what I showed in the previous slide, if you use this O to E, elevated O to E ratio as a proxy for risk, the risk appears concentrated in the first week after vaccination in both males and females. Reporting rates are substantially higher in males compared to females and are higher for dose 2 compared to dose 1 for both sexes. In the age group 5 to 11 years, you'll see that we have an elevated observed to expected ratio in the male dose 2 0 to 7 day age sex dose strata. Otherwise, the reporting rates in that age group are within background incidence. Next slide. So now I'll move on to the CDC project on enhanced surveillance of myocarditis outcomes following mRNA COVID-19 vaccination and various case reports among children ages 5 to 17 years. This is actually 2 projects with 2 separate cohorts, 5 to 11 years and 12 to 29 years, and I'm taking bits of the second cohort to combine them into a 5 to 17-year-old age group. The purpose of this project was to assess functional status and clinical outcomes among individuals reported to have developed myocarditis after mRNA vaccination. And it's a 2-component survey conducted at least 90 days after the onset of myocarditis symptoms. It includes a patient or parent survey and a healthcare provider survey as well. Next slide. During the surveillance periods, bears received 430 reports of myocarditis or myopericarditis after vaccination in this age group that met CDC case definition and were at least 90 days post-myocarditis diagnosis. We were able to complete 190 patient or parent surveys and 226 cardiologist or other healthcare provider surveys. These are the healthcare providers doing the aftercare for these myocarditis case patients. Next slide. So the main finding based on cardiologist or healthcare provider assessment were that most patients appear to have fully or probably fully recovered from their myocarditis. Of the 226 patients, we were able to contact the cardiologist or healthcare provider. They were judged by their provider 80.1% to be fully or probably fully recovered. Next slide. So the key findings, at least 90 days after myocarditis diagnosis, most patients who were reached, this was the patient survey, reported no impact on their quality of life, and most did not report missing work or school. As I mentioned, most healthcare providers who completed surveys indicated the patient was fully recovered or probably fully recovered. Of note, there was substantial heterogeneity in initial and follow-up treatment and testing, and there did not appear to be a single test that was indicative of recovery. The next steps, which is occurring right now, is additional follow-up with patients who are not yet fully recovered at the 90-plus day survey, and also with their healthcare providers to further assess recovery status at 12-plus months. Next slide. So now I'll move on to findings from the Vaccine Safety Data Link, which is, excuse me, CDC's electronic health record-based system that's used for surveillance and research. Next slide. So VSD conducts rapid cycle analysis, which is weekly sequential monitoring. The aims are to monitor the safety of COVID-19 vaccines using pre-specified outcomes of interest and to describe uptake of COVID-19 vaccines over time among eligible VSD members.
Dr. Shimabukuro, you went on mute.
I'm sorry, I was just coughing. Next slide, please. These are the VSD COVID-19 vaccine RCA pre-specified surveillance outcomes and the settings in which they're being monitored. Next slide. So the primary analysis in VSD RCA is a vaccinated concurrent comparator analysis. It's looking at vaccinated patients only, looking at cases in a risk interval compared to cases in a comparison interval, adjusted and matched by certain characteristics. And for the pre-specified outcome, myocarditis and pericarditis, which is a combined outcome, the cases were verified using the CDC case definitions. Next slide. This shows the Pfizer vaccine doses administered in VSD pediatric age groups. See the 5 to 11, 12 to 15, and 16 to 17 year age groups. Of note, over 2 million total Pfizer primary series doses have been administered to children ages 5 to 17 years during the surveillance period. Next slide. And here are the booster doses administered in the VSD pediatric age groups. Next slide. With respect to myocarditis, there have been no statistical signals to date for myocarditis and pericarditis in the analysis in children ages 5 to 11 years. We have primary series vaccination only. At this time, there weren't sufficient booster doses to do analysis. And for people ages 12 years, which does include adults, statistical signals were detected for myocarditis and pericarditis for Pfizer and for both mRNA COVID-19 vaccines combined for primary series vaccination, and statistical signals detected for myocarditis and pericarditis for both mRNA COVID-19 vaccines combined for first booster dose. Next slide. This is a graph showing cases with symptom onset of verified myocarditis and pericarditis cases among children 5 to 17 years after either primary series dose of an mRNA COVID-19 vaccines. And similar to the figure I showed you for VAERS, you see this clear clustering of cases, symptom onset within days 0 to 3 and days 0 to 4 in the VSD data for primary series. Next slide. So this is a table of verified myocarditis and pericarditis in the 0 to 7 day risk interval among male children in the age group by dose. It's split into two separate analyses, 5 to 11 years and 12 to 17 years, and we have some subgroup analyses for the 12 to 17-year-old age group. You'll see that there, the adjusted rate ratio is the statistic, and you'll see that we have no statistically significant elevated rate ratios in the age group 5 to 11 years for myocarditis or pericarditis, and but very small case counts. And then for 12 to 17 years, we have elevated rate ratios following dose 1, dose 2, and booster dose, with the rate ratio most elevated after dose 2 at 160 and highly statistically significant. When you look at the subgroups within that age group, 12 to 15 and 16 to 17, you'll see elevated rate ratios as well. They're highlighted where they are statistically significant. For the 16 to 17-year-old age group, we are not able to estimate rate ratios because there were no events in the comparison window, but we can estimate a lower bound of the 95% confidence interval. And so you see after dose 2 and after booster dose, both of those are statistically significantly elevated. Next slide. This is the same table, but for females. And so you'll see, notice a couple things. First of all, the case counts, the events in the risk interval and comparison interval substantially lower than for males, as you might expect. And the adjusted rate ratios tend to be lower, and there's less significant adjusted rate ratios. There's a statistically significant elevated rate ratio in females in the 12 to 17-year-old age group for dose 2, and in the 12 to 15-year subgroup for dose 2 as well. Next slide. So this table just shows straight VSD incidence rates of verified myocarditis and pericarditis in the 0 to 7 days following vaccination. See the general trend here is that incidence rate is higher in males compared to females and tends to be higher, highest in dose 2, although in some age and sex strata, the incidence rates are higher for booster doses, but those are relatively small case counts and very wide confidence intervals, overlapping with the confidence intervals of the dose 2 estimates. Next slide. This table shows the level of care and status for the cases after the primary series and booster dose, which are quite similar. Most of these patients were admitted to the hospital. Most of them had relatively short lengths of stay, 2 days or 1 day, and 100% in both cases were discharged home. Next slide. So I'm going to wrap up here with some findings on comparative risk of myocarditis between the two available vaccines, Moderna and Pfizer. Next slide. First, I'll just present some data that was previously presented back in October. This is data from the Vaccine Adverse Event Reporting System. Next slide. This is reporting rates per million doses administered among males. You see Pfizer on the left-hand side of the table and Moderna on the right, and highlighted there the ages where you can do a comparison because those are the ages in which both vaccines were authorized. And the general trend is whether you're looking at dose 2 or dose 1, the reporting rates tend to be higher for Moderna compared to Pfizer. Next slide. This is the same table, but among females. First, you'll notice that the reporting rates are substantially lower for females, but there is this similar trend where the reporting rates, whether it's dose 2 or dose 1, tend to be slightly higher for Moderna compared to Pfizer. Next slide. So those VAERS reporting rates are not a direct comparison. That's really a side-by-side comparison, looking at the data individually by individual product. To do a direct comparison, we turn to the Vaccine Safety Data Link. Next slide. So this is, and again, this was presented back in February 4th. This first figure shows case counts, onset, and incidence of myocarditis cases following Pfizer and Moderna. First, you'll notice that you're seeing the same clustering where the cases tend to cluster within several days after vaccination. And you see higher, if you look at the lines, the blue line Moderna, the red line Pfizer, you'll see a higher rate from Moderna compared to Pfizer in this 0 to 7 day risk period. Next slide. When we do a formal statistical comparison, you'll see that, and this is Moderna versus Pfizer, the statistic is a rate ratio. You'll see that in all of these analyses, whether you're looking at either dose 1, dose 2, looking at both sexes combined or male and female, you'll see these consistently elevated rate ratios, although some of these confidence intervals on these point estimates are quite wide. And then on the top there, a statistically significantly elevated rate ratio when you look at either dose for both sexes combined, 1.61, statistically significant, which translates into 8 excess cases in the risk period per million doses for Moderna compared to Pfizer. Next slide. And this is just the straight incidence rates of verified myocarditis and pericarditis 0 to 7 days following vaccination, with Pfizer there on the left, in the left column, and Moderna on the far right column. And you'll see that the general trend there is that there are that higher incidence rates, post-vaccination incidence rates for Moderna compared to Pfizer. This is rate per million doses administered. Next slide. So to sum all this information up, the current evidence supports a causal association between mRNA COVID-19 vaccines and myocarditis and pericarditis, with cases clustering within the first week of vaccination. Myocarditis is a rare event following vaccination. CDC has verified 635 myocarditis case reports in children ages 5 to 17 years after 54.8 million Pfizer doses is administered in this age group in the United States. The risk appears greatest in adolescents in the age group 16 to 17 and 12 to 15 years, and is generally higher after dose 2 compared to dose 1 of the primary series, and in males compared to females. In VSD analysis, in a minority of age and sex strata, incidence is highest following booster dose. The reporting rate in VAERS of myocarditis following Pfizer in male children ages 5 to 11 years after dose 2 of the primary series is slightly elevated when compared to background rates. Otherwise, reporting rates are within background incidence. And to date, myocarditis and pericarditis has not statistically signaled in VSD rapid cycle analysis surveillance in children ages 5 to 11 years. Next slide. The available information suggests that most persons with myocarditis after mRNA COVID-19 vaccination recover from their myocarditis by 90+ days after diagnosis. And in age groups where product comparisons can be made, some evidence suggests that myocarditis and pericarditis risk may be higher after Moderna than after Pfizer. However, the findings are not consistent in all U.S. monitoring systems. Next slide. I'd like to acknowledge the following groups for their contributions to this presentation. Next slide. I want to remind our state and local public health partners and our partners in the healthcare community and parents and caregivers that we are enrolling children into VSafe, and we need your help in promoting VSafe in practice. Healthcare providers can provide the VSafe information and can direct patients to the VSafe website. Ideally, this should occur before vaccination. And please provide these sheets, as I said, or display information about VSafe. VSafe is the way that we can quickly evaluate the basic safety profile of vaccines. Parents need to enroll themselves before they can enroll children, but we strongly encourage enrolling children into VSafe, and we appreciate any assistance that our healthcare providers can give in making sure that parents and caregivers are aware of the VSafe program. Next slide. Our clinical immunization safety assessment project is also available to U.S. healthcare providers who wish consultation on complex adverse events following immunization. Next slide. Next slide. That concludes my presentation. I'll be happy to take questions.
Thank you so much, Dr. Shimabukuro, for that very complete overview of the data to date. We're going to actually turn to Dr. Kip Talbot to provide the VAST assessment, and then we'll take questions on both presentations. So if we could move to Dr. Talbot's slide.
Thank you. So I'm going to give a vaccine safety technical work group assessment of the data that has just been presented and some other data that we were able to see, and I'll give the highlights of those. This is a lot of information, and I'll try to explain as we go. This is also in collaboration with Dr. Hopkins, who's my co-chair from NVAC. Next slide. So as a reminder, COVID-19 Vaccine Safety Technical Work Group, otherwise known as VAST, has the following objectives: review, evaluate, and interpret post-authorization approval COVID-19 vaccination safety data. To serve as a central hub for technical subject matter expertise from federal agencies conducting post-authorization and approval safety monitoring. Advise on analyses, interpretation, and presentation of vaccine safety data, and to provide updates to the ACIP COVID-19 Vaccines Work Group and the entire ACIP on COVID-19 vaccine safety. Since December 21st, 2020, we have been meeting and have met 59 times to review vaccine safety data. Next slide. VAST reviewed data about the Pfizer-BioNTech vaccine in 5 to 17-year-olds and compared data on safety monitoring for Moderna and Pfizer in the older age groups. And so to put that in context, as we are looking at data from Moderna today for 6 to 17 years of age, we've looked at the use of the Pfizer-BioNTech vaccine, which is a similar vaccine in those 5 to 17 years of age, and then we compare the two in older age groups where both are available. Next slide. I'm going to step through each of the different safety systems. We'll start with VSafe, which you just heard an advertisement for, and so you'll see that we do get very important data from that, and I encourage everyone to please use it. So from the VSafe data, we were able to get injection site and systemic reactions. So this is data from Pfizer-BioNTech in children ages 5 to 11 years of age. The reactions are generally mild to moderate, and most are reported the day after vaccination. Reactions more frequently reported after dose 2 than dose 1, and patterns in these children is generally similar to those observed in older age groups. Next slide. If you look at the V-safe data in the older age groups, so where we compare the Moderna to the Pfizer, you'll see that injection site and systemic reactions reported are reported more frequently after Moderna than Pfizer. Next slide. There's enhanced and the enhanced follow-up. Myocarditis following the Pfizer-BioNTech vaccination in 5 to 17 years old. The 54.8 million Pfizer-BioNTech doses have been administered to children ages 5 to 17. There have been 27.7 million doses of dose 1, 23 million dose 2, and 3.8 million first booster doses in this group 12 to 17. Theirs has had 635 myocarditis case reports that met the CDC case definition. The symptom onset clusters within several days of vaccination, mostly within the first 0 to 7 days. Reporting rates are generally higher for males than females, especially for age groups 16 to 17 and 12 to 15. Differences by sex in children ages 5 to 11 are much less pronounced. The reporting rate of myocarditis in male children ages 5 to 11 years after dose 2 of the primary series is slightly elevated when compared to background incidence. Otherwise, reporting rates for both sexes seem similar to background incidence. Enhanced follow-up of myocarditis cases, which was just covered, most patients reported no impact on quality of life, missing school or work. And most healthcare providers indicated that the patient fully recovered or probably fully recovered. Next slide. This is information from the VSD, the Vaccine Safety Data link. This is the information from the Pfizer-BioNTech vaccination in children 5 to 11 years of age. Approximately 878,000 children aged 5 to 11 years of age in VSD. 41% had completed the Pfizer-BioNTech vaccine primary series, and no statistical signals in the 21-day risk interval for any outcomes identified. Next slide. This is VSD when we compare Moderna versus Pfizer. So this is the myocarditis, pericarditis, days 0 through 7, post-vaccination among those 18 to 39 years of age, where both the Moderna and Pfizer vaccine are available. Both vaccines are associated with increased risk of myocarditis, pericarditis in 0 to 7 days post-vaccination, particularly after dose 2. No noticeable differences in level of care and clinical status between the cases after Moderna or Pfizer. Most cases were hospitalized and had stays of 1 day or less. Direct head-to-head comparison in ages where possible provides evidence that the risk of myocarditis and pericarditis may be higher after Moderna than after Pfizer vaccination. Next slide. This is a newer one. This was not presented in the previous talk, but this is BEST, which is the Biologics Effectiveness and Safety System that the FDA is performing, and we're very grateful that this information has been shared. 5.4 million Pfizer-BioNTech vaccine doses in children ages 5 to 17 years of age have been given. In the 5 to 11-year-old group, no statistical signals have been identified. In the 12 to 15 and 16 to 17-year-old group, myocarditis and pericarditis have been identified. Next slide. Still using the BEST system, we're looking at myocarditis and pericarditis in those 18 to 25 years of age in the Moderna and Pfizer vaccinations head-to-head. Not really head-to-head, but occurring. Pardon me. There's a large study in several U.S. administrative health plans databases of people aged 18 to 64 years of age. The occurrence of myocarditis, pericarditis after COVID-19 messenger RNA vaccination was rare. 95% confidence intervals for the incidence rate ratio comparing the brands range from 0.8 to 1.94. The risk is highest in men aged 18 to 24 years of age, 1 to 7 days after dose 2. Among 18 to 25-year-old men, elevated rate ratio for Moderna versus Pfizer-BioNTech vaccination, but this was not found to be statistically significant like in other systems. Next slide. So this is a summary of all of that data, and this alone is this slide alone summarizes all the data safety monitoring systems that we have discussed, but just for the Pfizer-BioNTech vaccine in ages 5 to 7. So VSAFE shows patterns of reports for local and systemic reactions similar for all age groups. VAERS reporting rates for myocarditis exceed background for ages 5 to 11, 12 to 15, and 16 to 17, mainly for dose 2 and booster, and then for females, 12 to 15 and 16 to 17, but for dose 2 only. VSD shows a risk for myocarditis, pericarditis is elevated, greatest in age groups 16 to 17 and 12 to 15, and is generally higher after dose 2 versus dose 1 of the primary series, and in males versus females. No statistical signals have been seen in children ages 5 to 11 years of age at this time. The best system shows risk appears greatest in groups age 16 to 17 and 12 to 15 years of age, generally higher after dose 2 than dose 1. No statistical signals for children ages 5 to 11, and only statistical signals for 12 to 15 and 16 to 17-year-olds for myocarditis and pericarditis. Next slide. This is another summary of lots of data for the 4 different surveillance systems, which we've mentioned, that this will be comparing the Moderna and the Pfizer in the older age groups. VSAFE showed higher frequency of local and systemic reports after Moderna than Pfizer-BioNTech vaccination in persons aged 18 years and older. VAERS showed slightly higher myocarditis, pericarditis reporting rates for Moderna versus Pfizer-BioNTech vaccination for both males and females in age groups where comparisons were possible. VSD in head-to-head analysis in 18 to 39-year-olds, myocarditis, pericarditis risk higher after Moderna than Pfizer-BioNTech vaccination. And BEST in head-to-head analyses in 18 to 25 years old, myocarditis risk higher, myocarditis, pericarditis risk higher after Moderna than Pfizer, but was not statistically significant. Next slide. So in summary, there is a risk of myocarditis, pericarditis after both messenger RNA COVID-19 vaccines. Most cases had prompt improvement in symptoms, and follow-up surveys suggest most fully recovered from myocarditis. Risk has been observed in adolescents and adults. Potential risk under assessment in children less than 12 years of age. We will continue to monitor this age group. Continued monitoring and natural history studies needed for myocarditis, pericarditis following messenger RNA COVID-19 vaccination. And this is important to understand rates, outcomes, risk factors, and mechanisms. Monitoring data for Moderna vaccine are available for persons aged 18 years of age and older who receive a 100 microgram dose. Currently, the EUA is for a 100 microgram dose for those 12 to 17 years of age, 50 micrograms for 6 to 11 years of age. And it's unknown if this lower dose of 50 micrograms will pose a lower risk. Next slide. VAS will continue to review safety data from multiple U.S. safety systems in specific age groups and after primary series and boosters. We'll continue to collaborate with global vaccine safety colleagues on key issues. We will continue to provide updates to the ACIP COVID-19 vaccines work group and to ACIP at future meetings. Next slide. This is the village that makes this possible. I'm incredibly grateful for everyone who participates and have attended every single one of these meetings. I'd especially like to thank my co-chair, Robert Hopkins, who represents NVAC, and our 2 CDC leads, Lori Markowitz and Melinda Wharton. Thank you.
Thank you so much, Dr. Talbot. And with that, we will have both Dr. Shimobukuro's and Dr. Talbot's presentations open for questions and discussion. Thank you, Dr. Paling.
Yes, good morning. Thank you both Dr. Shimabukuro and Dr. Talbot for presenting a lot of information and so clearly. The question, I very much appreciate all that you and your teams are doing and how clearly you present the data. The question that I have is when we reviewed data from Canada, we saw that persons that received vaccine primary series 8 weeks apart or more had less evidence of myocarditis. Is there any signal or is there any plan to evaluate if we see that through any of these surveillance systems? Thank you.
Hi, this is Dr. Shimabukuro. I think one thing we've noticed, and this is mainly from information we've got from our vaccine safety data link system, is that adherence to the schedule in the United States is quite high. Most persons get their second dose of the primary series at 21 days, on or about 21 days, and on or about 28 days as per recommendation. I think in Canada, it's a bit of a different situation because there are actually alternate recommendations on the dosing for the booster. So they had more data to actually make that assessment. In the United States, we have pretty limited data to make that assessment, again, because adherence to the recommended schedule is quite high. We can look, and as we continue to collect data, we may get more information on some of these alternate intervals between first and second dose. But right now we don't really have sufficient information to assess that.
Thank you, Dr. Long.
Yes, it's a question about, well, first of all, the occurrence of mild pericarditis following the booster dose was the only part that surprised me. And I anticipated it would be lower. I thought it was lower when I first looked at it, not when we heard about it from MCIP. And it makes me wonder if you've noticed, probably Dr. Shimabukuro, but Vas may have thought about this too. If this is getting more common following booster doses, because I've simplistically thought that this occurs at the second dose when it's frequently on the heels of the first dose because there's high resting antibody. And so I wonder with the prevalence of Omicron now, if, number one, booster doses are more likely to be associated in the recent past than before Omicron, and we would probably only have the older people to really consider that, or maybe not even them. And also, if the studies that we have done that said people need a booster dose are still valid with the ubiquitous nature of this virus, there's just nothing about this pandemic that doesn't change. So a lot of questions in one, if you might just free associate a little bit on this, on what you might know about the occurrence of mild pericarditis over time, and especially after booster dose.
When you say occurrence over time, are you referring specifically to vaccine-associated myocarditis?
Absolutely,
Okay.
absolutely.
All right. So I think in general the data are showing that the reporting rates and the risk when you look at the rate ratios are lower after booster dose compared to dose 2. But when you look at the incidence rates, it's a little less clear. So I think the general trend is for a lower risk after at least first booster dose compared to dose 2. There may be multiple reasons for that. an interval may be an explanation for that. In some cases, there is a lower dose for the booster dose, and also it may be that there may be some selection out. People who got myocarditis after dose 2 aren't getting a booster dose. So we will continue to monitor safety of additional booster doses, and because myocarditis and pericarditis has signaled and we have established a causal relationship, that will be a focus of our surveillance. So I think we'll continue to gather more information. But I think that at least the data we have right now, it doesn't appear that the risk is greater for the booster dose after dose 2. If anything, I think the general trend is it looks like there may be a lower risk after at least the first booster compared to dose 2.
This is Nikki Klein. Can I speak to that just a minute, if you don't mind, Tom? Dr. Shimmer-Peru. I just want to point out that in addition to the rate ratios appearing to be numerically lower after the booster dose in our analyses, the VSD, than after the second dose, all of our analyses are very, very tightly adjusted for calendar time. So with the issues of the Omicron that were raised by Dr. Long and other things, those are sort of taken into account when we do our analysis for our booster dose, if that's helpful.
Yeah, Dr.
Actually,
yeah,
Dr. Lee, can I follow up on that? Because there was a previous question following up on Dr. Klein's comment, which I clarified at another Federal Advisory Committee meeting, and it had to do with is the VSD rapid cycle analysis impacted by circulating virus, where you may be you may be doing comparisons between different people at different times, and disease circulation, virus circulation may be impacting the results. But as Dr. Klein said, the VSD RCA is controlled for time, so that at least circulating virus, whether there's high infection or whether any particular variant is circulating in any region, should generally be controlled for in the VSD rapid cycle analysis. And I would ask Dr. Klein to confirm that as well.
That's correct. Yes. Thank you.
Thanks.
Thank you, Dr. Sanchez.
Yes, thank you. No, those were really very important, and thank you, Tom and Dr. Talbot for these presentations. They really provide great information. I guess my comment or question, it really does seem to be, I think there's two issues that we're looking at is interval, as was mentioned previously, but also, and I think it's been mentioned, is the dosing, because the less cases in the 5 to 11 year of age, to me, suggests that the actual dose may be important, and then the perceived less cases in Pfizer versus Moderna. I know that with all of the issues and not great comparison, that may also be the case. So I think those are two important things that really need to be looked at to see how we can further minimize this risk in the age group that is at highest risk. And I wonder how many of those young males are being impacted. And I don't know if the number of males in that age group are receiving less. I know it wouldn't affect the rates, but if they're receiving less booster doses because of this concern. But and then my question is the issue of vaccinating with prior myocarditis, pericarditis being reported. I know that the CDC uses states that it's a precaution and not a contraindication from what I remember. Do you keep track of that as well to see how many have been vaccinated post an episode of myocarditis?
So we are aware of some case reports of persons with myocarditis being vaccinated. Again, I'm not aware of any recurrence of myocarditis in a vaccinated patient with prior myocarditis. I will say though, it's a fairly rare. It's probably a fairly rare occurrence. So I don't think we have sufficient data to assess risk right now, what is essentially what you're describing would be a re-challenge. But I do want to say, getting back to your previous point about risk in these younger age groups. I mean, if you can go back quickly to slide 4 of my presentation, that's possible to flip back there. With respect to the 5 to 11-year-old age group, I mean, this is just the natural history of myocarditis, and we've noticed that vaccine-associated myocarditis tends to follow the same general trend as classic myocarditis. The 5 to 11-year-old age group is really a very low-risk group for myocarditis in general. So, I mean, in addition to potentially a lower dose, this is just a lower risk group in general.
Thank you.
Thank you, Ms. Bata.
Thank you, and I really do appreciate this update, Dr. Shigella. I kind of want to go back to the discussion that was raised when we talked about long haul COVID and seeing a cluster, at least in my area of Minnesota, of people who are developing chronic symptoms after vaccination. And if there is any looking into this, maybe this isn't happening to the level of creating a signal, but it certainly seems to be a distressing pattern for the people experiencing these chronic long-term symptoms after they've been vaccinated. Can you say anything more about that?
Sure. Just to build on what I said earlier in response to that question. I mean, we are aware of reports of people experiencing, debilitating and long-lasting health problems, and we acknowledge that this can be disruptive and stressful, and we also acknowledge that these problems can substantially impact both the patient and those around them, and we wish for improvement and recovery. But with respect to our systems and our monitoring, I mean, most adverse events reported after COVID vaccines are mild and transient events like injection site and systemic reactions. Our safety systems and our monitoring systems are robust and have identified rare serious events and unanticipated conditions like thrombosis with thrombocytopenia and myocarditis. But our systems are dependent on identifying patterns in specific diagnoses or patterns and symptoms following vaccination. And that's how we found TTS, and that's how we found myocarditis. Some patients who become ill experience a wide range of symptoms that can make diagnosis and treatment for their condition challenging. And I understand this can be frustrating for patients and families and their doctors. It also makes it difficult to identify whether or not these illnesses are linked to vaccination. Both CDC and FDA use methods that can identify unexpected patterns or diagnoses or symptoms, but it still requires a detectable pattern. And without a specific diagnosis, which in many cases this is what we're dealing with, it's much less likely to be found, meaning these specific patterns in our surveillance. But we understand that people are experiencing substantial health problems, and we will continue to monitor the safety of these vaccines, and we will continue to, work with partners, both within the federal government and with healthcare providers and provider organizations to better understand these types of adverse events.
Thank you.
Thank you. Dr. Daly.
Yeah, so I have a question about sort of our long-term plans for risk mitigation and risk reduction, and I'm not sure who best to direct this to, perhaps Dr. Beigel or if he's unavailable, Dr. Shimabukuro. But sort of what are the plans to study the biology or the pathophysiology of this? And I ask that in the hope that we better understand it and then we're better able to reduce it in the future. And then there's a second question that's related to that, which is if again, Dr. Beigel or others on the call could help me understand the exact dose difference between these two different vaccine platforms, because when we hear of 25, 50, or 100 micrograms for Moderna or 310 or 30 micrograms for Pfizer, is that an apples to apples measurement, or does that include other things that come along with the mRNA so that it's not an exact comparison of dose amount? Thank you.
Yeah, so this is John Beigel. So I will get you a written response. I'm not aware of any studies specifically evaluating the pathophysiology as you suggested, but let us delve into that and get you a written response to make sure I do a comprehensive review of all the possible paths for that. And then I'm trying to think who is best situated for your second question. I'm not sure it's within my purview.
Dr. Daly, could you repeat your second question?
Well, so there are cited micrograms differences between Moderna and Pfizer, and I'm just trying to understand if those are measuring the exact same thing or if they're measuring something different, and we can't really say this dose is 10 times higher than that dose when we're comparing across platforms. And Dr. Beigel, I apologize for putting you on the spot, but I appreciate your answer. Thank you.
Dr. Dale, I have to defer to the folks in the immunization program on that question.
Why don't we give them a moment to respond? As we're doing that, Dr. Paling, maybe you can answer your question, and we'll ask the folks in the room if they can also identify a response to Dr. Daly's.
Okay. Thank you. I wanted to go back to the question that Ms. Bata had. So I understand that there are people who seem to be having these long symptoms after vaccination and that they're very heterogeneous. And if I recall correctly, we talked about CISA and the availability of a consultation. Is there any works to have CISA help us understand what's going on, or is that a possibility? Provide some more insight. Thank you.
So the CISA Clinical Consult Service is really available to consult with U.S. healthcare providers that request a consultation on a specific patient, and largely the issue is how to manage the patient moving forward, and issues about additional vaccination. I think what you're describing is more of a broad issues analysis of this condition. And again, I would just say that in the absence of diagnoses or being able to really hone in on a specific pattern, it does make monitoring quite difficult. I just want to reinforce that we recognize we acknowledge that there are reports of people experiencing these conditions. It can the presentation can be quite heterogeneous and variable, and that really makes it difficult to assess whether a vaccine, what role, if any, vaccination may have played but we're certainly exploring ways to further assess these conditions and to work with partners, particularly healthcare partners, to better understand these kinds of adverse events.
Ms. McNally.
Dr. Schumann-Bacot, can you remind us of the impact of other countries' safety monitoring systems in the VAST review and in the ISO's office in the work to monitor the safety, especially as it relates to myocarditis and pericarditis? Thank you.
Well, we do have regular contact with international partners. And in particular, we've spoken to our colleagues in Canada, and we've been briefed by our colleagues in Israel on VAST calls. So certainly we do take into consideration data from multiple sources outside of the United States. With respect to myocarditis, I think that the data have been remarkably consistent, both across systems and across other public health and regulatory agencies that are looking into this condition. And if there, I may ask Dr. Talbot to chime in, but we routinely do invite international partners from regulatory and public health agencies and academic institutions to brief the work group so we can get their perspective, and so we know what is going on outside of the United States and outside of U.S. safety monitoring systems.
Thank you. Dr. Duchin.
Thank you. Good morning. Thank you so much for following the safety issues so assiduously. Tom, my question is about the myocarditis outcomes study. And it looks like about half of the reports have been able to have follow-up, either through the parent or the healthcare provider. And I'm wondering, if you have any sort of words about, the implications of, following up half of that cohort. Is the other half similar, or do they differ in any way, or do you think it tells us that there's maybe some limitations on the interpretation of the cohort that was able to be followed up? Thank you.
Thanks, Dr. Dushin. I don't have the information available right now on how the individuals who we were not able to get a hold of or who declined to participate, how they may compare to the individuals in the cohort that decided to participate in the survey, or that we were able to contact the healthcare provider and they decided to participate in the survey. I don't believe that there were any substantial differences, but I'd have to check that and get back to you. I would say with respect to the project to follow up on the long-term outcomes in these case reports, we made every effort to try to reach out to individuals and the healthcare providers in advance to try to improve to try to maximize the response rate. And we are, in addition, we are actually following up for the longer term follow-up at 12 plus months. We are actually reaching out to patients that we weren't able to contact during the first iteration of interviews, where we spoke to the provider, but we didn't get a chance to contact the actual patient or the parent. So we are making efforts to try to reach these individuals to make sure that we get as much information on their recovery status and their functional status in the long term.
Thank you.
Thank you. I just want to acknowledge we're running fairly far behind schedule today, but I'm glad we had the opportunity to make sure that all the questions were asked and answered. Actually, I forgot to go back to Dr. Daly's question. I don't know if anyone wants to comment on that, and then I'd like for us to move on to the next presentation. That can get pulled up in the meantime. It might just be me, but I can't hear anybody.
Grace, we hear you. There's nothing coming from the room.
Okay. Did we lose the room?
I don't think we lost the room. Is Dr. Das able to speak?
Yes. No, I'm on. Yeah.
Let's see, Dr. Das. Dr. Oliver, sorry. I just wanted to clarify, and I might have missed the answer, but just to respond to Dr. Daly's question about the microgram dosing, is there anybody who can respond to that?
Oh, apologies. Sorry. Yeah. I mean, we're again defer to the manufacturers, and would love it if actually Moderna wanted to comment as well. But we can say that, you know, fundamentally, a Pfizer vaccine at 30 micrograms compared to a Moderna vaccine at 100 micrograms, there's different components. There's the spike protein, there's the lipid nanoparticles, and it's certainly not that they are a one-to-one comparison, in that we do not expect that the Moderna vaccine at 100 micrograms would be, you know, 3 times as high as Pfizer at 30. They have both, you know, been shown to elicit similar levels of antibodies and efficacy. There are some differences between the two, but we certainly do not expect that there would be, you know, a dose response that 30 micrograms of one vaccine would be directly comparable to 100 micrograms of the other, and that we would expect, you know, three or more times the response.
Thank you. And Dr. Das, the floor is yours. And if you would like to address that along the way, that would be terrific. Thank you.
All right. And is it okay if I share my screen? And I will,
Yeah, thanks, Dr. Das. I think we're handing it over to you.
Okay, perfect. All right, yeah, I can do it now, and I will share, and yep, and I'll put it into presentation mode. And did I get the 2 screens, 1 screen thing right this time?
It looks right. Please go ahead.
Okay. All right, great. So good morning. Again, my name is Rita Das, and I'm the Vice President of COVID-19 vaccines at Moderna. You know, in January of this year, our 100 microgram 2-dose primary series was approved in the U.S. for adults 18 years and older after being authorized for emergency use since December of 2020. You know, 1273 is authorized or approved in 86 countries for a primary series worldwide, and in boosters, and in 48 countries for boosters. And our vaccine is now authorized for children and adolescents 6 to 17 years of age outside the U.S. For adolescents, the 100 microgram 2-dose primary series is available in 42 countries, and we've had approval for the 50 microgram 2-dose primary series in children 6 to 11 in 40 countries. More than 6.4 million adolescents and 300,000 children have been fully vaccinated with a primary series of mRNA 1273 outside the U.S. So we're here today to discuss the use of mRNA 1273 as a 2-dose primary series for the prevention of COVID-19 caused by SARS-CoV-2 in adolescents 12 to 17 and in children 6 to 11. And then the proposed 2-dose primary series of the 100 microgram for adolescents, 50 for 6 to 11, are to be administered 1 month apart. So here's our pediatric development program, which has 2 clinical studies. Study 203 is adolescents 12 to 17. That enrolled more than 3,700 participants, nearly 25 of whom received mRNA 1273. Study 204, and the whole study 204 enrolled children 6 months to 11 years, and we discussed 6 months to 5 years last week, and we'll focus on the 6 to 11-year-olds today. And more than 3,300 children in this study received the mRNA 1273 at the 50 microgram dose. So in total, we have 5,800 children in this whole age group, so which established a substantial pre-licensure safety database. So here's the median safety follow-up times for the studies. In study 203, the entire study was blinded and placebo-controlled, and then this trial has now had about 11.1 months at the time of the data cut that I'll show you of follow-up time. And then in study 204, where we investigated the lower doses, we started with this open label dose escalation design, and then the second part of the study did the placebo-controlled trial, and we have about 8 months of follow-up from the open label portion and 5.6 months of follow-up for the larger study cohort. So in both studies, safety was a primary objective. Specific safety endpoints included local and systemic adverse reactions that were collected for 7 days post-vaccination. All unsolicited events were captured for 28 days, and then serious medically attended and adverse events of special interest were followed throughout the whole study. And then let's talk a little bit about the myocarditis, pericarditis follow-up in some more detail. So since myocarditis emerged as a post-authorization safety signal, this occurred when both studies were already ongoing. We updated our fact sheets, investigator brochures, and informed consent forms to increase awareness among investigators, study participants, and their parents. These conditions were also specified as adverse events of special interest to ensure that they would be reported rapidly. And then to further increase the sensitivity of detection, a script was added to ask about the CDC symptoms of myocarditis and pericarditis during safety follow-up calls on day 8 and day 36 post-vaccination. And then the clinical database was also actively reviewed for any symptoms which could have reflected myocarditis. All potential events were submitted to an independent cardiac endpoint adjudication committee, which was composed of expert cardiologists. And then we had 2 overlapping approaches to evaluate all unsolicited AEs for any potential cases for myo or pericarditis. We used a standard MEDRA query first, and then second, we developed an algorithm that was generated using the MEDRA terms included in the CDC case definitions. And of course, our ongoing post-authorization safety studies continue to capture myocarditis and pericarditis as adverse events of special interest. So vaccine effectiveness was the primary objective in both of our studies. It was successfully inferred by meeting the predefined immunogenicity criteria, which were agreed upon beforehand with the FDA. In each age group, immune responses were compared to the subset of adults 18 to 25 years of age from the 301 study, where we had the efficacy demonstrated against SARS-CoV-2. The younger adult subset was chosen to ensure a sufficiently high bar for the inference of vaccine effectiveness, given that immune responses in younger adults have been observed to be higher than those in older adults. So there were 2 non-inferiority criteria, which I'll go over quickly since we discussed them last week also. So first, the lower bound of the GMT ratio had to be at least 0.67. The point estimate had to be 0.8. And then again, in discussions with the FDA, we discussed that a point estimate of 1 was preferable, particularly if any doses lower than 100 micrograms were selected. And then second, the lower bound of the difference in the seroresponse rate, which is a 4-fold rise from baseline, had to be greater than -10%. And then efficacy evaluation was a pre-specified secondary objective in the trial. As in the 301 study, there were 2 case definitions applied. The CDC case definition, which requires 1 systemic or respiratory symptom, and the P301 case definition, which requires 2 systemic or a single respiratory symptom. Both case definitions required a nasal swab positive for RT-PCR for SARS-CoV-2, and then the CDC case definition was considered primary since children tended to have less severe symptoms of COVID-19 than adults. So as the studies were conducted and efficacy follow-up was performed, as we kind of have discussed before, the predominant SARS-CoV-2 strains changed. And then we have to look at the efficacy results kind of in that context. So during the 301 study, the original strain was almost exclusively circulating. And then the efficacy follow-up for the adolescents was conducted when the original strain and alpha variant were circulating. And then for the 6 to 11-year-old cohort, they were followed when Delta variant was the dominant variant. So next, I'll start with the review of the safety, immunogenicity, and efficacy data from the adolescent study. So a total of 3,732 adolescent participants were randomly assigned 2 to 1 to receive either 100 micrograms of 1273 or placebo. The dose level and schedule were identical to our adults in study 301. And then the interval between doses and our study participants were extremely compliant with this, was 1 month apart. Now, participants have received a booster dose subsequently and are being followed for an additional 12 months. So this slide shows the demography for the 1273 and the placebo group. Overall, the 2 groups were very well balanced. On this slide, we have the percentage of participants reporting solicited local reactions, which were injection site pain, erythema, swelling at the injection site, as well as axillary swelling or tenderness after dose 1 and dose 2. The lighter blue depicts the mRNA 1273 group compared to the placebo group in gray. The lower row represents the results from the P301 young adults, and the mRNA 1273 young adults are in the darker blue. So injection site pain was the most commonly reported solicited local adverse reaction after either injection. The majority of the reported events were grade 1 or 2 in severity and lasted for a median of 3 days. The reactions were reported approximately at the same frequency after doses 1 and 2, and were reported more frequently in the mRNA 1273 group than in the placebo group. The reactions were also reported more frequently in adolescents, than in young adults. Now this slide shows the solicited systemic adverse reactions. Headache and fatigue were the most commonly reported adverse reactions, and it's set up exactly the same way as the last slide was, followed by myalgia and chills. The majority of the systemic reactions were also grade 1 or 2 in severity, with a median duration of 2 days. Consistent with the established safety profile of mRNA 1273, systemic reactions were reported more frequently post-dose 2 than post-dose 1. The reactions tended to be reported at a similar to lower rate in adolescents than in young adults. And this suggests that the reactogenicity profile for the 100 microgram dose in adolescents is acceptable and generally comparable to young adults. So this slide has the percentages of the unsolicited adverse events reported up to 28 days after vaccination. 21% of participants in the mRNA 1273 group and 16% of the placebo group reported unsolicited AEs, and 13% and 6% respectively were considered by the investigator to be potentially vaccine-related. The imbalance was primarily driven by reports of lymphadenopathy and injection site reactions. The percentage of medically attended adverse events was similar between the 2 groups, and there were very few SAEs, severe AEs, or AEs leading to discontinuation, and no vaccine-related SAEs or deaths were reported. We have long-term safety data now for a median follow-up of 11.1 months after dose 2 for the original vaccine recipient. The adverse event profile here was typical for this age group, and no new safety concerns were identified. The most commonly reported medically attended adverse event was COVID-19, although importantly, there were no serious adverse events of COVID-19. The increased rates of COVID-19 likely reflect the Omicron surge and the fact that these participants were nearly a year out after vaccination when a number of these events were reported. There were no confirmed cases of myo or pericarditis in the long-term follow-up. And given the importance of these events, I'd like to also discuss at this point our post-authorization surveillance for since mRNA 1273 is authorized for adolescents in 42 countries worldwide. So here are the rates of myocarditis post-vaccination per million doses administered. And these data come from our global safety database and are analyzed by age cohort, dose number, and gender, with the males depicted in blue and the females depicted in pink. Consistent with other reports in the published literature and what we discussed today, we see higher reporting rate for myocarditis after dose 2 in males. The highest rates were in males 18 to 24 years of age after dose 2, with approximately 43 cases per million doses. That rate for the adolescents was 13.3 cases per million doses. So for comparison, Block et al. Recently reported the incidence of myocarditis after SARS-CoV-2 infection. The incidence of myocarditis in adolescent and young adult males diagnosed with SARS-CoV-2 is over 500 cases per million, suggesting that the rate is substantially higher than after dose 2 of mRNA 1273. So now we will review the primary effectiveness objective. The primary hypothesis was to demonstrate that immune responses in adolescents were non-inferior to young adult cohorts in the 301 study, where efficacy of the vaccine against COVID-19 was demonstrated. The first criterion was the GMT ratio in the adolescent group over the young adult group. The observed GMT ratio was 1.1 with a lower limit of 0.9. The second criteria was the group difference in seroresponse rate. The rate was 98.8% in the adolescent group and 98.6% in the adult group, with a difference of 0.2 percentage points and a lower limit of minus 1.8. Therefore, the primary effectiveness hypotheses were met. Next, we'll discuss vaccine efficacy, which was evaluated as a secondary objective. In terms of the case definition used by the CDC, there were 7 cases reported in the placebo group and 1 reported in the mRNA 1273 group for a vaccine efficacy of 93.3%. And if a more stringent case definition from study 301 was used, there were 4 cases reported in the placebo group and 0 cases in the mRNA group, and the observed vaccine efficacy was 100%. Now we'll turn our attention to the 6 to 11-year-old group from study 204. We discussed before, study 204 was conducted in 2 parts. First, to identify the correct dose of mRNA 1273 in children 6 to 11, and then to evaluate that dose in a randomized placebo-controlled study. In part 1, 2 doses of mRNA 1273 were evaluated in an open-label design. The lower 50 microgram dose was selected as it showed an acceptable tolerability profile and demonstrated a high likelihood of meeting the pre-specified immunogenicity success criteria. After part 1 was completed, a DSMB meeting occurred to ensure the committee's concurrence with the selected dose. Part 2 was designed to randomize the children, now in a 3-to-1 ratio, to receive either mRNA 1273 or saline placebo. The data we will present today focus on the randomized phase of the study 204, which evaluated the 2-dose 50 microgram primary series in children 6 to 11 years. All study participants will be followed for 12 months after their last dose of vaccine. So here are the demographics for the children ages 6 to 11. Again, these were well matched among vaccine and placebo recipients. The mean age in both age groups was 8.5 years, and with a good balance of males and females. So starting the review of our safety findings, this slide shows the solicited local reactions in the children 6 to 11 years of age. The mRNA 1273 is in blue and the placebo is in gray. Pain was the most common event with similar rates and severity following dose 1 and dose 2. Most local AEs, including pain, were grade 1 or 2 with a few grade 3 reactions. The median duration of local adverse reactions in this age group was 2 to 3 days. Turning to the systemic reactions, fatigue and headache were the most commonly reported systemic adverse reactions. Reporting rates for fatigue and headache were similar to those seen in the adolescents and young adults. The rest of the systemic adverse reactions were reported at a lower rate in these older children compared to the young adults. The rates of systemic adverse reactions post-dose 1 were similar to placebo, and among vaccine recipients, systemic adverse reactions were more frequently reported post-dose 2 than post-dose 1. Again, events were mostly grade 1 or 2 in severity, with a median duration of 2 to 3 days. Next, we can discuss the unsolicited adverse events. Presented here are the unsolicited adverse events reported up to 28 days after any injection in children 6 to 11 years. 30% of participants in the vaccine group compared to 25% in the placebo group reported any unsolicited adverse reaction. The imbalance in AEs was primarily driven by local AEs and axillary swelling or tenderness, similar to what was seen in adolescents. Medically attended adverse events were similar among the two groups at 13 and 14%, and there were no SAEs considered related to vaccination by the investigators reported. There were no fatal AEs, events of MIS-C, or myocarditis, pericarditis. We now have long-term safety data for a median duration of 5.6 months among the original vaccine recipients. This table has a cumulative incidence of the unsolicited AEs through this time. No new safety signals were observed, and there were no deaths related to SAEs or adverse events of MIS-C or myocarditis in this original vaccine group. We also collected safety on the original placebo recipients who got vaccine in the crossover. There was one related SAE after vaccination. This was a case of ileus reported in a participant with a complex GI medical history from the placebo crossover group. Next, we'll turn our attention to the immunogenicity data. Immunogenicity was a primary objective of the study. After the 2-dose 50 microgram primary series in the 6 to 11 group, the GMT was 1,600 in the older children compared to 1,300 in the young adults. This resulted in a GMT ratio of 1.2, meeting the pre-specified non-inferiority criteria. The seroresponse rate was 99.1% and also met the non-inferiority seroresponse criteria. On to the efficacy assessments, which was a secondary objective. Assessment of placebo-controlled vaccine efficacy in the 6 to 11 age group was limited due to the authorization of another COVID-19 vaccine. Per the study protocol, participants were unblinded then to offer them access to mRNA 1273. The number of COVID-19 cases in the per protocol population post-dose 2 with a 1.8 median follow-up time was small and did not allow for meaningful assessment. I'm going to present the assessment then that was conducted in the MITT population, which was based on a higher number of cases. And this is because the MITT population allowed counting of cases 14 days after post-dose 1. The MITT calculation is typically a more conservative calculation because it does not require the follow-up time after the full vaccine dosing, and it allowed an additional month for case accrual. The overwhelming majority of study participants, though, did receive their second dose of vaccine. So here are the efficacy results for the MITT cohort. Efficacy was high at 88% using the broad CDC definition, and it was 92% using the more stringent Study 301 definition. Additionally, as we discussed before, this trial was conducted during the Delta period, so this represents direct efficacy against the Delta variant. The immune response of mRNA-1273 has been remarkably consistent across age cohorts, despite administering lower doses to children. This slide depicts the immune responses ranging from young adults to children in our pediatric program. Across the pediatric age groups, the ratio of the ratio of immune responses compared to those young adults, 18 to 25, ranged from 1.01 to 1.28, successfully meeting all of our immunogenicity hypotheses. So the totality of data from our pediatric development program in these age groups, from 8,000 children, 5,800 of whom received vaccine and had a median duration of follow-up of over 5.6 months, support the benefits of mRNA-1273 in school-age children and adolescents, and that these benefits outweigh the known and potential risks. mRNA-1273 was generally well tolerated, with a safety profile consistent with that observed in young adults, and no new safety concerns have been identified. Our pediatric studies were designed to meet the FDA criteria for inference of vaccine effectiveness compared to young adults, as the vaccine efficacy in a population of adults has already been demonstrated. In both age groups, the co-primary immunogenicity hypotheses were met. In addition, there was evidence of efficacy against COVID-19 conferred by mRNA-1273, ranging from 88% to 100%, both during the original Alpha and Delta variant circulation. We've established a robust plan to continue to evaluate safety and effectiveness, both in our clinical trials and in post-authorization studies. I'd like to conclude this presentation with an enormous and heartfelt thank you to the entire community who made these studies possible. Without the support and sacrifice of our study investigators, our site personnel, our colleagues at BARDA, NIH, and COVI-PN, and most importantly, the children and their families, this effort would not have been possible. So thank you very much, and I'd be happy to take any questions.
Thank you, Dr. Das. Presentation is now open for questions. Thank you, Dr. Paling.
Thank you, Dr. Das, for a very clear presentation on both the immunobridging data as well as effectiveness data and the safety data. I wanted to go back, and if you could highlight a little bit more about any grade 4 adverse events that were detected in either cohort. Thank you.
Yes. So in the 6 to 11 cohort, there were no grade 4 events. There was no for either local or solicited systemic adverse events. In the adolescent group, let me refresh my memory. In the adolescent group, there were no grade 4 local solicited adverse reactions. There were 4 grade 4 systemic adverse reactions post-dose 2. 3 of those occurred in vaccine recipients, and 1 was in a placebo recipient. And in the vaccine recipients, they were events of fever, headache, and nausea, vomiting.
Thank you. And if you have slides, that would be terrific. I tend to be more visual. So, Dr.
Yeah, I can show you this slide, although it's of questionable value because it doesn't come up on the slide as a little bar because it's kind of small, but I have it footnoted in the bottom of exactly what the grade 4 events are.
Thank you. Dr. Daly?
Yeah, thanks so much. Thanks, Dr. Das, for this presentation and for all the work behind it. I have a couple of safety questions, and then I'm going to come back to this dose question. Could you go to slide 18, please?
Slide 18, yes. Let me share. Okay. Okay. Slide 18. Yes. Please go ahead.
So this I found this very, very interesting and helpful, and I just wonder if you could tell us about the data source. So it looks like, and perhaps kind of what the strengths and limitations of the data source are, because this looks like an estimate, for example, of 13.3 cases of reported rate of myocarditis per 1 million doses administered, dose 2 for adolescents 12 to 17. So, kind of what's that data source and what are the strengths and limitations of that data source? And then I have a couple other questions. Thank you.
Sure. So this is our global safety database. So all of our global reports for myocarditis are contained here, and it is, and the denominator is the estimated per million doses administered by the different age groups. I think the limitations are certainly that it is passive reporting. It is kind of what is entered into our global safety database. We attempt to get as much information on the cases as we can. I think we are not as good as the CDC assessments are at times in terms of being able to get all of the detailed follow-up, which I think is kind of a challenge for everyone.
Okay, so that's direct reporting by patients, parents, or providers to the manufacturer. Is that correct?
Yes, exactly.
Okay, thank you. Then could you go to slide 32?
Yes. The 32 here, yes.
So I'm going to start with the dose question and then transition to a safety question. But the dose question is, what's being measured when you say there's 100 micrograms? And is that just mRNA or mRNA plus what comes with it? And related, sort of then, how does that translate into how a 50 microgram dose compares to a 100 microgram dose, for example?
Yes, so this dose is the mRNA content. And so the ratios are exactly as you would expect for the mRNA content.
So what's being measured there is only the mRNA and not like nanolipid particles or other things that come along with it. Is that correct?
Correct.
Okay. Then I realize this may be an unanswerable question, but do you think that post-vaccination myocarditis has any sort of dose response?
Yeah, and I think from the data I presented from our clinical database, it would be very hard to opine on that. So, I really don't know.
Okay, thanks. That's it for my questions. Dr. Lee, back to you.
Thanks, Dr. Daly. Dr. Sanchez.
Yes, thank you. Thank you for the presentation. But getting back to Dr. Daly's question, because I think it is really critical that we know what is exactly being measured. And then because we really do need more information on the pathogenesis so that we can try to prevent it. And so is there a standard measurement of messenger RNA content do you measure, is there any standardization of that? Or does each company or each person, laboratory, measure messenger RNA differently? And I guess what I'm trying to get at is your measurement of 50 micrograms, 100 micrograms, can we correlate? Is it measured the same way as Pfizer's 30 micrograms?
So we have a validated method for mRNA measurement, and that's how we are reporting our doses. I'm not aware of other vaccines measurement methodology. We might need to ask others to comment on that. Perhaps the FDA has a better idea of that.
That's what I was wondering, if the FDA also may be able to comment on that as they review the different manufacturers'
I think Dr. Fink mentioned he'd be in and out today, so I actually don't know if he's available at the moment. Yeah, I don't see him coming on. He's on, but I think I can see an away sign for a moment. You know, I'm happy to ask, but I do think that this question is going to keep coming up. So I think it'd be really helpful if both Moderna and Pfizer could, if there's any written responses that can be provided, I think that would be incredibly helpful.
Thanks, Dr. Lee.
Yeah, and we'll take that back as well.
Thank you. I don't see any other hands raised. I just want to confirm. Any other questions for Dr. Das before we move on?
Please. I have
one last
question.
Dr. Sanchez? Okay.
Yes, I'm sorry.
Okay.
And I've asked this before, and I just don't have a clear idea of how long the spike protein that the messenger RNA in our bodies produce, how long has it been detected in patient serum or tissues, and maybe, you know, even in animal studies? You know, how, I know that, you know, it is said that the messenger RNA disappears quite quickly, but do you know, first of all, how long it may persist in blood or serum or tissues? And also, do you know what is the molecular weight of the spike protein that our bodies do produce? And I guess I'd say that with respect to transplacental transfer as well. But I mean, this is a separate issue. But those are issues that have, you know, that I've brought up previously, and I really don't have an answer. I don't know if anything new has been developed on those. Thank you.
No, thus far, you know, we have looked at the detectability of spike protein, as well as the mRNA. You're absolutely right. The mRNA degrades quite quickly. The spike protein availability, I believe, is on the order of days, but like less than a week. But I will confirm that with our tox folks as well. And then your other question was about the molecular weight of the spike protein. So, I mean, we do have the full spike here, but I will take that back to get the, you know, the molecular weight, which would be expected for the full spike.
Thank you. Dr. Bailey, last quick question, and we have to move on.
Okay, it's quick. Dr. Das, could you comment about thoughts about interval with respect to myocarditis and future plans that you have with respect to studying that? Thank you.
Yeah, no, it's an excellent question, and you know, we looked again at all of our studies, and the interval is very tight. You know, the most we were trying to see if we could, you know, tease out like a 6-week interval, but it gets very small. We are doing an 8-week interval in our infant study. And we were going to do that because so it would coincide with childhood immunizations better. We have heard the feedback about about studying at least the immunogenicity at the longer intervals, and you know, certainly our animal studies show that that the longer intervals are good for immunogenicity. So you know, we have heard the feedback, and we will take it back and see what we can do from a clinical study immunogenicity standpoint in terms of the interval.
Thank you, and thank you very much, Dr. Das, for your presentation. We'll move on to Dr. Sarah Oliver, who will present on the evidence to recommendation framework for the Moderna COVID-19 vaccine in children and adolescents ages 6 to 17 years of age.
Great, thank you so much. Feels like we just did this, but here we go again. So back with ETR framework. Next slide. Next slide. Next slide. So these are the policy questions we'll be talking about today. Should the Moderna COVID-19 vaccine 2 doses at 50 micrograms be recommended for children ages 6 through 11 under the EUA? And should the Moderna vaccine 2 doses at 100 micrograms be recommended for adolescents ages 12 through 17 under the EUA? Next slide. This is our PICO question with a comparison group of no vaccine. Next slide. And again, our ETR domains and questions. We'll be addressing individuals 6 through 17 overall, but we'll highlight differences where we have 6 through 11 and 12 through 17 data. Next slide. So for the public health problem, next slide. This graph shows the pandemic epi curve with trends in number of COVID cases in the US among persons of all ages. Then as of mid-June, there have been more than 85 million total recorded cases of COVID-19 in the US. Since April, we've seen an increasing number of cases, although that's been leveling out since late May, with our current 7-day average around 100,000 cases. Next slide. Then in total during the pandemic, over 5.1 million cases have occurred among children ages 5 through 11, and more than 5.6 million cases have occurred among adolescents ages 12 through 17 years. Next slide. Then the slide illustrates the rate of COVID-19 cases by vaccination status and by age group. In April, unvaccinated individuals ages 5 through 17 overall had 2 times greater risk of testing positive for COVID compared to children and adolescents vaccinated with at least a primary series. Next slide. Then moving to hospitalizations, this figure shows COVID-19 associated hospitalization rates per 100,000. In blue, you can see the hospitalization rate among adolescents 12 through 17, and in orange, among children ages 5 through 11 years. As you can see, there's been an increase in hospitalizations among both children and adolescents during the peak of the Omicron surge, leading to the highest hospitalization rates for these age groups to date during the pandemic. Next slide. Then we know that vaccination prevents hospitalization. Here are the monthly COVID-19 associated hospitalization rates by vaccination status. Adolescents 12 through 17 years in dark blue who were vaccinated with a primary series or with a primary series plus one and maybe one or more booster dose with the solid lighter blue line had lower hospitalization rates than those who were unvaccinated in the dashed line. Although children ages 5 through 11 years in orange have lower hospitalization rates overall than adolescents, the same pattern can be seen after they became eligible for vaccination in late 2021. It's also important to note that the benefits of vaccination are always more pronounced when the disease burden is high. Again, we can predict with future COVID-19 surges, the unvaccinated will continue to bear the burden of disease. Next slide. Then to put the burden of COVID-19 illness in context, this figure's from a recent paper which used data from COVIDNet and FluServeNet, which conducts surveillance for influenza-associated hospitalizations from October 1st through April 30th of each year, the typical US influenza season. The solid black line is COVID-19 associated hospitalization rates during October 20th through September 21st. And the solid red line is the preliminary COVID-19 associated hospitalization rates during October 2021 to April 2022. The influenza associated hospitalization rates from 2017 through 2020 are shown by flu season in the gray and dashed red line, and the dashed red line is the preliminary data for the most recent flu season. Next slide. Among children ages 5 through 11 years, COVID-19 hospitalization rates from October of 2020 through September of 2021 were lower than influenza hospitalization rates during the 2017-2018 or through 2019 and 2020 flu seasons. However, in this group, the preliminary hospitalization rates during the 2021 through April of 2022 flu season, which included the Omicron surge, were as high or higher than the influenza hospitalization rates for the prior included influenza seasons. Next slide. However, when we look at adolescents 12 through 17 years, the cumulative rates of COVID-19 hospitalizations for both years are considerably higher than influenza hospitalization rates during all the prior influenza seasons. Next slide. Now moving to mortality associated with COVID-19, this figure shows the number of COVID-19 deaths in children and adolescents by single year age group from January of 2020 through May of 2022. These data are from the National Center for Health Statistics and are based on death certificate reporting. Among children 5 through 11 years, there were 443 COVID-19 related deaths. among children 5 through 11, there were 189 COVID deaths, which represent 2.5% of all deaths in this age group. Next slide. Then among adolescents 12 to 17, there were 443 COVID-19 deaths, which again is 2.4% of all deaths in this age group. Next slide. Now we'll take a look at the percentage of children and adolescents who've received at least one dose of the COVID vaccine over time. As shown, 36% of children ages 5 through 11 and nearly 70% of adolescents have received at least one dose of the COVID vaccine through mid-June. Overall, 18 million children ages 5 through 11 and 7.5 million children ages 12 to 17 years remain unvaccinated. Next slide. So in summary, children and adolescents ages 5 through 17 years are at risk of severe illness from COVID. There have been over 10.3 million cases reported in this age group, and to date, sadly, over 600 deaths. Children and adolescents who've received COVID vaccines have better outcomes than children who are unvaccinated, particularly against severe illness. But we know that 65% of children in the 5 through 11 group and 30% of adolescents have not yet received a COVID vaccine. Next slide. So the work group determined that yes, COVID among children and adolescents was of public health importance. Next slide. Then moving to benefits and harms. Next slide. We know the time frame of when the studies were conducted is critically important in the interpretation of efficacy results. So just highlighting that the trial for those ages 12 to 17 years was conducted during the original or ancestral strain and into the Alpha variant. Then the study for children 6 through 11 years was conducted during Delta. Neither of these studies was conducted during the Omicron surge, which is different than the vaccine efficacy results we heard this past weekend, where the trials were conducted during Omicron. Next slide. So first, to review the data for children 6 through 11 years. Next slide. Overall, we have data from one study from the Moderna phase 2-3 randomized trial. Participants were randomized 3-to-1 vaccine to saline placebo. Data included all eligible randomized participants who received vaccination through the data cutoff of November 10th, 2021. The available body of evidence, again, is primarily from the Delta variant. The VE estimates do not represent the most recent epidemiology. Per protocol, there were 2 co-primary endpoints for efficacy based on immunobridging, the geometric mean ratios, and the seroresponse. And data on symptomatic COVID using various definitions was also supplied. Next slide. So in this table, you can see the efficacy estimates for symptomatic COVID. Using the CDC definition, the 2-dose vaccine efficacy estimate is 75.8%. When those with prior infection are included, the CDC definition in the vaccine efficacy estimate is 80.6%. But again, based on 8 total cases, each of these 2-dose estimates has a wide confidence interval. Next slide. The immune response to vaccine was evaluated using the geometric mean ratio of children to young adults. As we should be familiar with by now, but there's non-inferiority criteria, and they're met when the lower bound of the 95% confidence interval for the ratio comparing the geometric mean neutralizing antibody titers for the 2 groups is not less than a pre-specified value, which for this has been set at 0.67. So the immune response to the vaccine in children ages 6 through 11 was non-inferior to that observed in those ages 18 to 25 years with a ratio of 1.2. Therefore, the non-inferiority objective was met. Next slide. So the grade assessment for symptomatic lab-confirmed COVID using the direct efficacy had serious concerns of imprecision due to the small number of events, with a final evidence type of type 2. Next slide. The grade evidence assessment for the outcome of symptomatic lab-confirmed COVID using immunobridging had serious concerns of indirectness because immunogenicity is an indirect measure of efficacy. Again, the final evidence type was moderate certainty or type 2. Next slide. Then the next outcome of interest was asymptomatic SARS-CoV-2 infection. During the phase 2-3 trials, participants were evaluated for asymptomatic infection using a nasopharyngeal swab for PCR testing on day 57, or at unscheduled visits triggered by a SARS-CoV-2 exposure. Participants with documented COVID symptoms were excluded. There were 9 asymptomatic PCR positives among 2,600 vaccine recipients and 10 asymptomatic PCR positives among 853 placebo recipients for an efficacy estimate of 71%. Next slide. So for the grade assessment for this, there was serious concern of indirectness because the full cohort was only PCR tested on day 57, and serology was not done for all participants. Therefore, the results do not represent full serial or serologic testing. There were also serious concerns of imprecision due to the small number of events, so the final evidence type was type 3. Next slide. Then these are the data on serious adverse events. In the phase 3 trial, there were 6 participants who experienced events among the 3,000 participants in the vaccine group, and 2 participants out of almost 1,000 participants in the placebo group for a comparison of 0.2 to 0.2%. No SAEs were deemed related to the vaccine. All participants who received at least 1 dose were included through the data cutoff. Next slide. So for the grade assessment, there were serious concerns of indirectness due to the short duration of follow-up. There were also serious concerns of imprecision due to the width of the confidence interval, which includes estimates for which other policy options might be considered. So the final evidence type was low certainty or type 4. Next slide. Then for reactogenicity, we've heard reactions were solicited through electronic diaries for 7 days after each dose. And as we've heard previously, the criteria for meeting grade 3 or higher are listed here and are generally preventing daily activity. Next slide. Then grade 3, local or systemic events were reported in 17% of persons in the vaccine arm and 3% of those in the placebo arm. No grade 4 events were observed in vaccine recipients. Next slide. So the grade for this, with a relative risk of 5, there were no serious concerns in the certainty evidence estimate. So the final evidence type was type 1. Next slide. So this table summarizes the grade assessment for the Moderna vaccine in children 6 through 11. In terms of benefits, the available data indicate the vaccine was effective at preventing symptomatic COVID with direct efficacy and indirect immunobridging, both with an evidence of type 2. Data also estimated the prevention of asymptomatic infection with a less certainty in the evidence of type 3. In terms of harms, serious adverse event reporting was comparable, but there was concern for indirectness and imprecision, so the evidence was type 4. Again, no SAEs were judged to be related to the vaccine. Reactogenicity was more common in vaccinated persons with an evidence type of 1. Next slide. So again, moving to adolescents, ages 12 through 17 years. Next slide. Participants were randomized 2-to-1 vaccine to saline placebo. Data included all eligible randomized participants who received vaccine through the data cutoff of May 31st. The available body of evidence, again, is predominantly from a time period when either the original ancestral strain or the alpha variant was the dominating circulating variant. So these VE estimates do not represent the most recent epidemiology. The data on symptomatic COVID was also supplied using various definitions. And again, as we've heard, per protocol, there were 2 co-primary endpoints for efficacy based on immunobridging, the geometric mean ratio and seroconversion. Next slide. In this table, you can see the efficacy estimates for symptomatic COVID among adolescents 12 through 17. Using the CDC definition, the vaccine efficacy estimate was 89%, based on 11 total cases. And this estimate from the CDC case definition is the one used in grade. Next slide. Then for the immunobridging assessment, again, the immune response to vaccine in those 12 to 17 was non-inferior to that observed in those 18 to 25 years with a GMR of 1.1. Therefore, the non-inferiority objective was met. Next slide. So this is the grade assessment for symptomatic lab-confirmed COVID using the direct efficacy, with serious concerns of imprecision due to the small number of events. Again, the final evidence type was type 2. Next slide. Then use the grade assessment for symptomatic lab-confirmed COVID using immunobridging. Again, serious concerns of indirectness because immunogenicity is an indirect measure of efficacy. So again, the final type was moderate or type 2. Next slide. Then for asymptomatic SARS-CoV-2 infection, Again, asymptomatic infection was measured in 2 ways, with seroconversion from blood drawn on day 57 and by a nasopharyngeal swab for PCR at day 57 and unscheduled visits triggered by SARS-CoV-2 exposure. There were 21 asymptomatic cases among around 2,000 vaccinated persons and 16 asymptomatic cases among just over 1,000 placebo recipients for an efficacy estimate of 36%, but the confidence interval was wide and included 0. Next slide. So for the grade assessment for asymptomatic SARS-CoV-2 infection, there were serious concerns of imprecision due to wide confidence intervals and study size. So the final evidence type was low or type 3. Next slide. Then these are the data on serious adverse events. There were 6 participants who experienced an SAE in the vaccine group, 2 in the placebo group, for a comparison of 0.2% to 0.16%. Next slide. So the grade for this, there were serious concerns for indirectness due to short duration of follow-up, and very serious concerns of imprecision due to the wide confidence interval and study size. So the final evidence type was type 4. Next slide. Then in the phase 3 study, again, grade 3 local or systemic reactions were reported in 25% of persons in the vaccine arm and 4.8% of persons in the placebo arm. The majority of these events were grade 3. There were 3 grade 4 events in vaccine recipients, 1 fever that was greater than 40 degrees Celsius, 1 headache, and 1 nausea vomiting. Next slide. So then the grade assessment for reactogenicity also had a relative risk of 5. There were no serious concerns in the certainty assessment, so the final evidence type was type 1. Next slide. Then again, this summarizes the grade assessment for Moderna COVID-19 vaccine in adolescents. Again, as we saw for 6 through 11, the efficacy estimates for both direct efficacy and immunobridging were type 2. Serious adverse event reporting was comparable, but there were concerns for indirectness and serious concerns for imprecision, so that was type 4. And again, reacto was type 1. Next slide. So overall, in conclusion, the efficacy seen after 2 doses of the Moderna COVID vaccine in children 6 through 17 years of age is consistent with the real-world vaccine effectiveness seen with SARS-CoV-2 variants at that time. Again, the alpha or delta, depending on the age. Antibody levels after 2 doses in children and adolescents 6 through 17 produced similar antibody levels after 2 doses in individuals aged 18 to 25 years. Reactogenicity after the vaccine is consistent with what's been seen in the Moderna vaccine in other age groups. Next slide. So now to walk through some myocarditis considerations. These are the slides from the safety presentation that we heard from Dr. Shimabukuro earlier, showing the rates of myocarditis after mRNA vaccine. The rates are the highest in males ages 12 to 29 years and after the second dose. Note that for those less than 18 years, the results are only for the Pfizer vaccine. Next slide. Then this slide is from a presentation previously shown to ACIP in February. Some, but not all, observational analyses of post-marketing data suggest that there may be an increased risk of myocarditis and pericarditis in males 18 to 39 years following the second dose of a Moderna vaccine relative to Pfizer. Next slide. In summary, and again, this was a summary from that presentation in February, the risk of myocarditis may be higher for Moderna than Pfizer, but there were important limitations to note. The data was observational. The rates were not readily comparable to differences in case definition and risk interval length, subpopulations, case ascertainment, calendar time, and implementation factors. Also, as we discussed then, there were a limited number of geographic locations that were administering both mRNA vaccines and had data available on myocarditis. Next slide. However, I think this was mentioned earlier, but ACIP at that time also heard data regarding the impact of extended intervals between dose 1 and dose 2. So from our Canadian colleagues, they showed that for both vaccine products, the overall myocarditis rates were higher when the interval between the doses was shorter, and myocarditis rates were lower with an extended interval between the 2 doses. Next slide. So in general, a summary of the myocarditis risk. It's unknown what the risk of myocarditis is after the Moderna vaccine in children and adolescents ages 6 through 11 and 12 to 17 years. Some observational data in adults suggest a possible increased risk after the Moderna vaccine compared to Pfizer. However, we do have information on risk mitigation measure for myocarditis. Extending the interval between dose 1 and dose 2 of these mRNA COVID vaccines to 8 weeks may further lower the myocarditis risk. Next slide. Then again, we've seen these slides before at the last ACIP meeting, but just highlighting what we know for 2-dose VE against severe outcomes, such as hospitalization and MIS-C in this age group during Omicron predominance. Next slide. So when we think through the known and potential benefits, we have the clinical trials to provide data for protection against symptomatic infection. The clinical trials weren't powered to detect efficacy against severe disease, but similar patterns are expected to what we see with mRNA COVID vaccines overall, with higher protection against severe disease. Then we heard earlier today that there's some emerging data in adults that suggest post-COVID conditions may be less likely to occur in vaccinated individuals. Next slide. The summary for known and potential harms. We have post-authorization safety data, again, after almost 600 million doses of COVID vaccines given in the US. Importantly, we also know that the risk of adverse cardiac outcomes were somewhere between 1.8 and 5.6 times higher after SARS-CoV-2 infection than after mRNA COVID-19 vaccination among adolescent males 12 to 17 years. And importantly, we have a mitigation measure as well, extending the interval between dose 1 and dose 2 of the mRNA vaccines to 8 weeks may also further lower the myocarditis risk. Next slide. So in summary, for benefits and harms overall, these clinical trials were conducted prior to Omicron predominance. And we do know that post-authorization vaccine effectiveness studies, particularly against infection, have shown lower VE against Omicron compared to previous variants. However, the Moderna COVID vaccine for older children and adolescents met the non-inferiority criteria for neutralizing antibody levels. We know that receipt of a primary COVID-19 vaccine series can provide protection against both COVID disease and severe outcomes. So overall, the benefits of the Moderna vaccine in both children and adolescents ages 6 through 17 outweighs the risks, and extending the interval between dose 1 and dose 2 to 8 weeks may further optimize that benefit-risk balance by lowering the myocarditis risk as well. Next slide. So the work group felt that the desirable anticipated effects were large. Next slide. The undesirable effects were small. Next slide. And that the desirable effects outweighed the undesirable effects and favored the intervention. Next slide. So moving to values. Next slide. Adolescents aged 13 to 18 years and parents of 13 to 18-year-olds were surveyed using national research panels on 3 occasions or waves. Wave 1 was before the COVID vaccine was available. Wave 2 is after it was available for adults, and Wave 3 is after it was available for those ages 12 and over. Parent survey responses regarding the importance of both routine vaccines and the COVID vaccines are presented here. COVID vaccines and influenza vaccines were rated similarly by parents. Overall, parents reported relatively high importance of getting the COVID vaccines, although at times was slightly less important than what was reported for other routinely recommended vaccines. Next slide. So now taking a look at parents' willingness to have their teen get the COVID vaccine and other routine vaccines together. We'll talk about this more later, but CDC and the AAP support giving other recommended childhood and adolescent immunizations at the same time as COVID vaccines, particularly for children and teens who are behind on their routinely scheduled immunizations. Parents were asked for the willingness to have their teen get a COVID vaccine and routine vaccine they may need at the same time, and you can see that 70% were supportive. For those who selected no or not sure, further information was collected, and actually the most common reason for not wanting that was that the teen was already up to date on their recommended vaccines. However, some parents did express concern regarding safety with concomitant administration. Next slide. Then if we look at over time uptake of the vaccine and willingness, parents of 12 to 17-year-olds, most parents say their teenager has been vaccinated. 56% from April, which has been fairly steady since January. While about 3 in 10 say they will definitely not get their teen vaccinated. You can see that over time, the wait and see population in light blue has declined. Next slide. These are similar results, but among parents 5 through 11 years who've been eligible for vaccination since early November. And about 4 in 10 say that their child has been vaccinated. 12% say they will only get their child vaccinated if they're required. 32% said definitely not. Interestingly, here you can also see that the wait and see population in light blue has declined over time, although in this age group, 10 to 13% of parents still have a wait and see approach. Next slide. Then from the same survey that was conducted, but this time in February, parents of adolescents expressed the most confidence in the safety of the vaccines for their children. Over half of parents of adolescents said that they were confident in the safety of vaccine, many of whom who had already been vaccinated. Slightly fewer parents were confident in the safety of vaccine for children ages 5 through 11. Next slide. Then adolescents themselves were surveyed to gain a better perspective of potential factors that would increase their intent. Potential factors among adolescents were more information on safety and efficacy, preventing the spread of COVID to family and friends, and importantly, resumption of or increases in social activities or traveling. Next slide. So in summary, over half of parents of adolescents 12 to 17 and nearly 40% of children 5 through 11 report that their child is already vaccinated, where around 30% of parents of both age groups report their child will definitely not get vaccinated. Parents of adolescents express the most confidence in safety, whereas fewer parents of children 5 through 11 are confident. And then further information on the vaccine and resumption of social activities are important to adolescents. Next slide. So the work group felt that it varied regarding how the target population felt for the balance of desirable and undesirable effects. Next slide. So then again, not surprisingly, there was important uncertainty or variability. Next slide. Now to acceptability. Next slide. Again, pediatricians and healthcare providers are the top trusted source for information about the COVID vaccines for children among parents across community types. While majorities of urban and suburban parents also trust their local health department or the CDC, rural parents are somewhat less trusting of these sources. And around half of parents across community types say their child's school has provided them with information on how to get a COVID vaccine for their child. However, smaller shares of rural parents say that their child's school has encouraged them to get vaccinated compared to parents in urban areas. This difference may play an important role in vaccine uptake for children across communities, as we previously have reported that parents whose children's school encouraged vaccination were more likely than those whose school did not encourage vaccination to say their child had received a vaccine. Next slide. Again, around half of all parents across community types say their child's school provided them with information around the COVID vaccine. However, again, we know that this varies by location. Next slide. Then we showed this slide previously for the broad approach jurisdictions had taken to provide COVID vaccines to children. Next slide. So now we have data on where children and adolescents actually received their COVID vaccines. Most children and adolescents received their vaccine at either their medical home or pharmacy. We saw this was even more important in the 5 through 11 population. Schools and other mass vaccination sites were used less frequently, especially for children in the 5 through 11 population. Next slide. So overall, most jurisdictions were utilizing a variety of implementation strategies to vaccinate children and adolescents. But we know that in this age group, most children are receiving their vaccine at either their medical home or a local pharmacy. And again, pediatricians or other healthcare providers are the top source for information about COVID vaccines for children among parents across community types. Next slide. So the work group felt that yes, the Moderna vaccine was acceptable to key stakeholders. Next slide. So for feasibility, next slide. We'll hear more information on this in the clinical considerations presentation to follow around the products for children 6 through 17 years. But in brief, focused on the products for children ages 6 through 11, 50 micrograms. The product ships at -20. The product that will be used has the same cap color as the product for young children, but a different color border. It has different concentration than the adult primary series, although the same concentration as the product for young children. However, note that the vial authorized for this age group will actually be labeled as booster dose 18 and over, and it does not require diluent. Next slide. Then for the product ages 12 through 17 years at 100 micrograms, this has a red cap with a light blue border and is the same product and vial as used for adults. It's given at the 0.5 ml volume for primary series in individuals 12 and over. And currently the 0.25 ml volume is also being given for booster doses for those 18 and over. There will not be a new NDC code for this, as it's the same product for primary series in 18 and over already available. And again, there's no diluent as well. Next slide. Then as we continue to roll out additional vaccines and additional vaccines products, just wanting to highlight vaccines.gov as a way that parents and their children can find a COVID vaccine. Next slide. So overall, these Moderna products for children and adolescents ages 6 through 17 years may be less familiar to pediatric healthcare providers. However, it's able to be stored at a traditional freezer temp and does not require diluent. The product for children ages 6 through 11 will be labeled as a booster dose for those 18 and over, which will require considerable education, and we'll hear more on that from Dr. Hall in a few minutes. The adolescent product is the same as the adult formulation and will be more familiar to providers. Next slide. So the work group noted that the vaccine is feasible to implement, although did note challenges with labels and the vials. Next slide. So for resource use, next slide. So again, it's the same slide that was shown last week. Overall, vaccines are currently available at no cost to the recipients, and given the protection against severe disease is likely to result in considerable reduction of healthcare cost. As we've mentioned before, cost effectiveness is not the primary driver for decision-making during a pandemic, but will continue to be reassessed. Next slide. So the work group felt that yes, the vaccines were a reasonable and efficient allocation of resources. Next slide. Then finally for equity, next slide. Looking at vaccination coverage and parental intent for children between the ages of 5 through 17, older children were more likely to be vaccinated with younger children, and multiracial and Hispanic children were more likely to be vaccinated than Black or white children. Next slide. This slide shows the coverage among children ages 5 through 11 by race and ethnicity. And in the box, it shows the percent of unvaccinated in the table, as this would be the population available for the Moderna vaccine. And note that it also varies by race and ethnicity, where nearly 72% of Black children 5 through 11 remain unvaccinated as of late April. Next slide. This slide again shows coverage among adolescents ages 12 through 17 with at least one COVID vaccine dose by race and ethnicity. And again, as we noted, the unvaccinated population varies by race and ethnicity, with just over 40% of both Black and white adolescents that are unvaccinated. Next slide. This slide shows the percent of children and adolescents ages 5 through 17 years by metropolitan statistical area, where coverage is again considerably lower among rural children. In the interest of time, we'll summarize potential drivers of this disparity by stating that rural parents reported less intent to vaccinate their children, lower vaccine safety confidence, and more than half of rural parents stated that getting their children vaccinated against COVID would be a bigger risk for their children than the COVID infection itself. Next slide. Then we have slides highlighting communication resource materials for vaccine providers and for partners. Highlighting, we have vaccine pages focused on vaccinating children with disabilities. Next slide. And again, the importance of culturally and linguistically appropriate materials, including fact sheets that are available in a variety of languages listed here. Next slide. And again, highlighting that we have focused resources to promote COVID vaccine for children and teens with diverse images. Next slide. So in summary, there are noted disparities in vaccination coverage and parental intent for children by race, age, race and ethnicity, and metropolitan statistical area. Communication materials that are culturally appropriate and diverse, including materials for children with special healthcare needs, are important. Next slide. Overall, the work group felt that there would potentially be no impact for equity with the additional Moderna products, but as we discussed last week, we know equity requires more of a call to action than a singular question. Next slide. So in summary, next slide. These are the work group interpretations for each of the ETR domains. Next slide. Then highlighting that the work group discussed each age group for the Moderna COVID vaccine primary series compared to no vaccine. And as we discussed last week, 2 vaccine options may allow parents and providers a choice. The Moderna COVID-19 primary series in older children and adolescents met the non-inferiority endpoints, providing protection against symptomatic COVID disease, and are expected to provide higher protection against severe disease. I wanted to bring up that the work group felt strongly that an interval of 8 weeks between dose 1 and dose 2 would likely improve both safety and effectiveness of the Moderna vaccine in older children and adolescents. Next slide. So then, as we will ask you for 2 separate votes, we'll show the summary and work group interpretations for each age group specifically. The Moderna vaccine in children ages 6 through 11, the work group felt that the desirable consequences clearly outweighed the undesirable consequences in most settings. Next slide. And the work group proposed to ACIP to recommend the intervention. Next slide. Then specifically for the Moderna vaccine in 12 to 17 years, the work group felt that the desirable consequences clearly outweigh undesirable consequences in most settings. However, again, highlighting that the work group discussed the 8-week interval would both increase the benefits and decrease the harms, improving the balance of consequences for the 100 micrograms of Moderna in adolescents. Next slide. But overall, the work group also recommended to ACIP to recommend the intervention. Next slide. So at this, I will turn it over to Dr. Hall, who thankfully has her voice back and will be able to walk you through these clinical considerations. Dr. Hall?
Thank you, Dr. Oliver. All right, next slide, please. So I'll start with the anticipated updates to the vaccination schedule. Next slide. So first, I'll present the pediatric schedule for Moderna COVID-19 vaccine for ages 6 through 17 years. It's the same for 6 through 11 and 12 through 17, so I've just bundled them together here. Starting at the top in teal for people who are not moderately or severely immunocompromised, this group should receive 2 primary doses separated by 4 to 8 weeks. Then shown at the bottom in gold is the schedule for people who are moderately or severely immunocompromised, and this group should receive 3 primary doses, each separated by 4 weeks. And just like when other COVID-19 vaccines were first authorized for a specific age group, only primary doses are authorized at this time for people ages 6 through 17 that receive Moderna primary series. Next slide. This slide simply shows all of the pediatric recommendations for those who are not immunocompromised. Depending on the age and product, people 6 months through 17 years should receive either 2 or 3 doses. Next slide. So this is the same thing, only for people who are moderately or severely immunocompromised. And depending again on age and product, people in this group should receive between 3 and 5 total doses. Next slide. So at the last ACIP meeting, we talked about considerations for an extended 8-week interval between dose 1 and dose 2. I won't go through all of these again, but just wanted to remind that the extended 8-week interval is particularly relevant to today's discussion with the adolescent group. It may be more appropriate than the 4-week authorized interval in situations when the priority is to reduce myocarditis risk. Again, some studies in adolescents and adults have shown the small risk of myocarditis associated with mRNA COVID-19 vaccines might be reduced with this longer interval. And use of this interval is especially important for adolescent and young adult males where higher risk has been observed, including males 12 through 17 years. Next slide. Next slide. So now we'll transition to the Moderna products for ages 6 through 17. Next slide. As a reminder, at the last meeting, we took a look at the product authorized for ages 6 months through 5 years. It has a dark blue cap and magenta border label. A dose is 25 micrograms or 0.25 milliliters. Next slide. Next, the product authorized and will be available for primary series doses for ages 6 through 11 years also has a dark blue cap, but the label border is purple. This product is also authorized for booster doses for adults ages 18 years and older. In the adult group, just boosters, not primary doses. The label for this product reads booster doses only in all caps, and we'll look at the label on the next slide, but it is authorized for primary doses in ages 6 through 11. For both the 6 through 11 and the 18 plus, the dose is 50 micrograms or 0.5 milliliters. Like all Moderna COVID-19 vaccine products, it should not be diluted, and there are 5 doses per vial. And because you may see it in the EUA, I will mention there is another product that is authorized for ages 6 through 11 with a dark blue cap and a teal border label. However, it is not available. So that's why I won't be going into detail on that one, and we'll only be discussing this one for ages 6 through 11 years. Next slide. Okay, so now we'll look at what that label actually looks like. As I mentioned, the product with the dark blue cap and purple border is labeled as booster doses only in all caps, but again, is authorized for primary doses in children ages 6 through 11 years and booster doses in adults ages 18 years and older. It also states on the label 2.5 milliliter multi-dose vial, booster dose 0.5 milliliters. However, again, the 0.5 milliliter is the correct dose volume for both the booster dose that it lists here on the label and primary doses for 6 through 11 years old. Next slide. So finally, the currently available product that we know and are familiar with for ages 18 years and older has been amended to include ages 12 years and older now. It has a red cap and a light blue label. A primary series dose will continue to be 100 micrograms or 0.5 milliliters for the 12 through 17 age group. And the booster dose is only authorized for 18 and older. So 12 through 17 can only receive the primary series dose at this time. Next slide. So we recognize that label for ages 6 through 11 stating booster doses in all caps is very confusing. There will be multiple education and communication materials and efforts to communicate the authorized use of this vial for ages 6 through 11. I'll point out a couple of things from FDA. There's a printable wall chart available at the link on this slide. Additionally, the EUA for ages 6 through 11 includes the picture of that booster only vial, both the label and the vial, to show what providers would actually see in their stock. Next slide. CDC will also have multiple products and communication efforts to communicate the use of the vial. The clinical considerations, of course, will be updated and have information on the different products. CDC has multiple product-specific job aids, including this at-a-glance job aid that I have a screenshot on the slide. The screenshot here is what is actually currently available online and does not include this new age group, but it will be updated for 6 through 17 as well. Other job aids like prep and administration summary will help as well. Additionally, we'll be educating through webinars, calls, and partners to help providers with this confusing label situation. Next slide. And as discussed at the last meeting, children should receive the age-appropriate vaccine product and follow the schedule based on their age on the day of vaccination, regardless of their size or weight. If a person moves from a younger to an older age group during the primary series or between the primary series and receipt of a booster dose, they should receive the vaccine dosage for the older age group for all subsequent doses. And then the booster is, of course, not applying to this particular product and age group combination. Next slide, please. So I'll just go through a couple of the FDA allowances for aging up, even though CDC recommends using the product based on age, day of vaccination. The FDA does have some different allowances. So for children who age from 5 to 6 years between any dose in the primary series, they may receive either the Moderna product authorized for children 6 months through 5 years, which is that dark blue cap, magenta label border, and the Moderna product authorized for children ages 6 through 11 years, the dark blue cap, the purple border. So shown on this slide, again, magenta or purple border, and then 4 to 8 weeks later can be magenta or purple border. Next slide. So then children who turn from age 11 to 12 years between any dose in the primary series may receive either the Moderna product authorized for children ages 6 through 11 years or the Moderna product authorized for children ages 12 through 17 years. So for dose 1, this would be the dark blue cap, purple border, or the red cap, light blue border. 4 to 8 weeks later, again, either one is acceptable, the dark blue cap, purple border, or red cap, light blue border. Next slide. Next slide. So existing guidance applies to children and adolescents ages 6 through 17 years. We went through this last week. Co-administration, as a reminder, COVID-19 vaccines may be administered without regard to timing of other vaccines. And interchangeability, the COVID-19 vaccines are not interchangeable. The same product should be used for all doses of the primary series. Next slide. So I just wanted to mention, with all of these new products out, there may be more opportunities for vaccine administration errors besides just the number of products. Of course, the products that are not labeled for the indicated age group. Additionally, new pediatric providers may be unfamiliar with COVID-19 vaccines, and there are some stark differences between routine vaccines. Some of the most likely errors to look out for with this context would be incorrect product or dose volume, resulting in a higher than authorized dose, incorrect product or dose volume resulting in a lower than authorized dose, a correct dose from an incorrect product, and vaccine administered past the beyond use date, particularly for new providers. The beyond use dates and times, they're just much shorter and may be unfamiliar for those who are used to routine vaccines. Next slide. So on this slide, I've listed some resources for preventing those errors, some strategies that could be put in place ahead of time. So first is a web-on-demand mini webinar. This is about 15 to 20 minutes, and you can watch it at any time. We have a handout for preventing vaccine administration errors, and of course, multiple job aids on vaccine storage, handling, preparation, and administration. Next slide. And finally, just a reminder of our more general resources. Next slide. Here we have all the interim clinical consideration links and associated supplementary materials. Next slide. Here is the landing page for all of the job aids for all COVID-19 vaccine products by product. Next slide. And finally, our consumer resources for recipient education with the links on this slide. And next slide, I will now hand it back to Dr. Oliver.
Thanks, Dr. Hall. So I will just wrap up and say, in summary, since the beginning of the COVID pandemic, among children ages 5 through 17 years of age, there have been over 10 million COVID-19 cases, over 45,000 hospitalizations, and tragically over 600 deaths. Again, we know that COVID can cause severe disease and death among children and adolescents, including those without underlying medical conditions. And as we continue to say, we know that future surges will continue to impact children, with unvaccinated children remaining at a higher risk of these severe outcomes. Next slide. As with all other age group, the priority is vaccination of unvaccinated individuals. There are 25 million unvaccinated children and adolescents right now. We know that the benefits outweigh the risks for mRNA COVID-19 vaccine in all ages. Receipt of this primary series continues to be the safest way to prevent serious COVID-19. Next slide. So the questions we'll pose to ACIP is, should vaccination with the Moderna vaccine, again, 2 doses at 50 micrograms, be recommended for children 6 through 11 years? And should Moderna at 2 doses 100 micrograms be recommended for adolescents 12 through 17 years? Next slide. And again, just want to acknowledge our entire team. Again, Monica Godfrey has pulled together a variety of ETR presentations, so thanks to her and the variety of people on this slide as well. It is absolutely a team effort, and so my sincere thanks to everyone here. Back one slide, and we can go back to the questions, and I'll turn it back over to you, Dr. Lee. Thanks.
Thanks. This presentation is now open for questions, and I wanted to ask a question. It's more for the manufacturers. As someone who cares about implementation, I wanted to ask our manufacturer colleagues to make it easier for us to do the right thing. I was looking at teal, magenta, maroon, orange, red, lots of blue, and sometimes with the same color cap and sometimes with a different color cap. And we have labels that are now different than how we're actually supposed to use it. So I really appreciate the CDC putting together the types of training and support we'll need to implement it, but just recognize that this does impact, acceptability from a provider standpoint, because there's a lot of complexity to incorporate into the busy practice. So my question is really, I recognize we have to address these difficulties by education for the moment, but can we focus on better design? I think that whoever can design an easy-to-use system for delivering these vaccines will be the most successful. So Pfizer and Moderna, I was wondering if you have any plans to improve the design and labeling of these vials, because to me, this is quite overwhelming, and I feel like I know COVID pretty well.
Yeah, this is Rita Das from Moderna, and I can start us off. We do definitely hear the feedback. I think this has kind of arisen with the speed with which these have come forward, but we absolutely take the feedback, and we are actively working on how to simplify this.
Thank you. Is there anybody from Pfizer on? Okay, maybe not today. We'll move to Dr. Palin. Dr. Palin, I cannot hear you, but it might be me.
Oh, there we go. Is that better?
That is. Thank you.
Okay, thank you. So first of all, I want to say thank you to Dr. Oliver and Dr. Hall for their great presentations. And I wanted to reiterate your point, Dr. Lee, about the confusion on the labels for both doses. And I also want to highlight that there are people who are colorblind, and I think that we're overly focused on the color. And I worry about that and contributing to errors. I wanted to go back for Dr. Oliver. You put up a slide about the percent in physicians' offices and pharmacies, which was the vast majority of vaccines. Could you, for children 5 to 11 and 12 to 17, could you put that back up?
Sorry, getting it there. Yes, this one.
Okay. Okay. All right. So between the two, over 80% are vaccinated in one of those two sides, if I'm interpreting that correctly.
Correct. I don't have comparison for the adult, although that would be interesting, and maybe we can show that at a future meeting. But we do know that for adults, there was much more of the mass vaccination site that was available. We knew this would likely be the case and planned accordingly. And then now we have the numbers to show that as we move to a younger age group and expect to see the same as we move in the under 5, under 6, that medical home is really the place that most people are going to seek out vaccine from.
Yes. Okay. And that's important. I think we've also talked last week about the importance of working with pharmacies and medical places and putting them into a registry so everybody knows what's going on. And so that's fantastic. Thank you. For the 2 questions you have, I agree with both of those questions. And then my question to Dr. Hall was getting into booster doses. So how I appreciated you had 2 slides about what happens for those who do not have immunocompromising conditions and those that have immunocompromising conditions. Can you help us understand what the booster dose recommendation is? Because that's not part of the vote, if I understand it correctly. Thank you.
Yeah, so, and this is another difficult communication point. So for Moderna 6 through 17 years, and actually for Moderna 6 months through 17 years, there is currently no recommendation for a booster dose, and that is because FDA has only authorized primary doses at this time and has not yet authorized a booster dose. But we would expect by the time, like assuming the same type of schedule that we're used to, the 5 months or the 3 months, we would assume by that time that these kiddos who get Moderna would actually be eligible, that there probably would be a booster dose authorized because we would have more data at that point. Sort of stepping outside of Moderna for Pfizer, that is where there is a booster dose authorized for children and adolescents. The youngest age group, 6 months through 4 years, not yet because we just don't have that data. But for 5 through 17 years, either 1 or 2 booster doses is recommended depending on the exact age and immune compromised.
Dr. Lee,
we do have an at-a-glance schedule that is probably much more helpful than all of that.
No, and I was just going to say, I don't know if Dr. Fink has been able to join us again. This was discussed, this is Sarah, this was discussed at VRBPAC as well, and FDA at the time acknowledged the gap where there are not recommended and authorized booster doses for Moderna, but expect that is not a permanent thing, and it would likely be fixed. But I don't know if Dr. Fink's been able to join us, but.
Hi, I am here, and thank you, Dr. Oliver. That is correct. We would expect to be addressing this gap in booster dose recommendations over the summer and into early fall. Thank you.
Thank you. Ms. Plata.
Thank you. Dr. Hall, I just need some clarification here. When you were talking about children needing a dose based on the age of the day they're vaccinated, but you went on to explain that there are exceptions related to the Moderna vaccine that they can get, if they're in that transition age, they can get either dose?
Yes, that's right. So I'll just use an example of aging from 5 to 6 years. So CDC's recommendation would be to use the product based on the age, the day of vaccination. So if we have a 5-year-old in the office, we're going to vaccinate them with the product for ages 6 months through 5 years. But within that 4 to 8 week interval, they age up to 6 years, and now they're in the office for the second dose. That day, we vaccinate them with the product authorized for ages 6 through 11 years. However, the FDA authorization allows actually for either of those products, ages 6 months through 5 years or 6 through 11 years, to be administered for either the first or the second dose. So some more flexibility around that. And we are working on putting together a visual on this because this is a very confusing concept. So hopefully we'll have that in the near future.
I think it would be really helpful to, I mean, this feels really complicated when I see it like this. And I'm thinking about the many states who provide consultation to clinics. It's almost as if really you should stick with the general rule that you give the dose for the age that they are on that day. But if that didn't happen, it shouldn't be considered a medication area. You don't have to fill out a VAERS or anything like that. I mean, otherwise it really is confusing.
No, completely agree. And yes, we are working to push that message that the default is CDC's recommendation, but if you happen to do this, it is not an error.
Thank you. Thank you, Dr. Sanchez.
Yes, thank you. And thank you for all of that. I just really, first of all, from Ms. Bada's comments, I agree. We need to be consistent. And then from Dr. Lee's comments, it is extremely confusing. Even the slides that you presented, Dr. Hall, about the, where you put dose 1, and I don't have it labeled as to which one it is. Children who turn from age 5 to 6 receive between any dose in the primary series may receive, and then you have dose 1 magenta or purple, and dose 2 magenta. I mean, it is really confusing. And so I urge the manufacturers to really get their act together to minimize any errors and certainly to improve safety. And I think also what would be very helpful when you present these is to actually put the microgram dosage rather than just go by, magenta or purple border or what have you, because I look at that slide and I'm like having to go somewhere else to see which one you're talking about. I just urge you, and the other thing that Dr. Palin had mentioned was color blindness, but I think that that we really need to work on putting, talking about micrograms as well whenever we mention any of these colors. Thank you.
Thanks for that feedback.
And Dr. Freihofer.
Yes, Sandra Freihofer, American Medical Association, speaking as a practicing physician to echo some of these concerns about the colorful caps and labels. I mean, they're confusing, they're complex. And I too am shocked that the concentration is not listed on the label. And my question is, are the products the same across each color-coded bottle other than the concentration? And that might need to be directed to the manufacturer. But again, all these, the colors, you worry about people that might be colorblind, and also just going cross-eyed looking at all these different colors. It's very confusing, very complex, and we really do need the concentration on those bottles as a final check before these doses are administered. But can one of the manufacturers answer that question about are they the products the same throughout each bottle, except for concentration?
Yes, I do confirm that. This is Rita Das from Moderna. The concentration is the only thing that's different. The product is the same.
So I know initially when the product came out, there was a little difference that was made to make it more stable, but that's been standardized throughout the remaining product.
Yes, the middle, the right two are the same. And then, as you note, the concentration of the 18 years and older or the 12 years and older, that one is the only.
Thank you. And Dr. Dawson, we appreciate you answering these questions, and we realize we don't have our Pfizer colleagues on this call today. So thank you for at least answering for Moderna. Dr. Hogue.
Yes, thank you. I want to go back again to try to make sure that I'm completely clear on something that Ms. Bata brought up, which is slide 15 of the clinical implementation, the clinical consideration slide. Pharmacists largely across the country, as they give vaccinations, follow, and maybe I've got the wrong slide. I'm sorry, I may be in the wrong presentation. I'm looking at the vaccine dosage slide that we've been talking about. Pharmacists are very focused on ACIP recommendations and CDC's clinical guidelines for the use of vaccines. And it's not unusual in the past to have had vaccine products which contain an FDA label that is for a different age range than CDC recommends. But we have been pretty strong at the American Pharmacists Association about promoting to pharmacists that you should always follow the CDC's clinical guidance. And I think that that's true as I work with my colleagues in nursing as well. I hear the same thing. So I just want to be absolutely clear that this vaccine dosage slide in Dr. Hall's presentation, the clinical recommendation, the clinical guidance from CDC for children is that they receive an age-appropriate vaccine on the day of their vaccination. And then if they progress to the next age, then they should receive that age-appropriate vaccine dosage for the older age group. And that is clearly the CDC's guidance and recommendation. The variations that you described are FDA allowed labeling, but I want to be completely clear so that pharmacists and nurses and others who administer this vaccine are crystal clear on what CDC's clinical recommendation is. I'm sorry to beat a dead horse on this, but we need to be very, very clear. It's confusing.
No, I'm glad you did, because you summarized it perfectly. That is exactly the case. The CDC's recommendation is to vaccinate based on the age on the day of vaccination. And all of these exceptions are FDA's allowances so that these doses aren't considered an error if one of these situations occurs. But this is CDC's recommendation shown on this slide.
Thank you. I appreciate that clarification. I think that will go a long way. And then, if I may, just real quickly, the teal colored label for the Moderna product is the one that is not yet available and would be at the appropriate age for the 6 to 11-year-olds appropriate dosage, if I remember correctly. One thing that I haven't heard addressed is on what time frame does Moderna plan to have that product available in the U.S. market so that we don't have to deal with these extraordinary mislabeled products where we're trying to deal with booster doses only versus it's acceptable for this age group sort of thing? Yes, this product. So when has Moderna, maybe Moderna could tell us what's the time frame for the teal product coming to market? How long are we going to have to deal with this potential nightmare of a situation with this product?
Yes, this is Rita Das again from Moderna, and we're actively assessing this. We don't have a definitive time yet, but we are actively addressing this.
Dr. Lee, can I add one more thing to what Dr. Hogue was saying?
Please do.
I just want to say we're in a slightly unique situation where we have CDC recommendations, but then the FDA has written into allowances. And I just want to highlight that Sometimes the reason we don't see this for other vaccines is we're in a really unique situation with the EUAs and the provider agreements and the PrEP Act. And so we just want to make very clear that, we have our CDC recommended get the dose on the day that you are. But I know that there has been a lot made for if people go outside of the EUAs and outside of the provider agreements, what happens. And so that is, I think, a very purposeful why they're included in the EUAs. So, people can have the assurance that is not considered an error. It's okay. Obviously, if somebody ages up, there is a little bit of flexibility around that. And that's kind of the unique situation that we find ourselves in with COVID vaccines, which is why it's a little bit different than what we're traditionally used to. But anyway, just wanted to provide that context, but also that we'll do everything we can to distinguish what is kind of the CDC, what is recommended that we ask providers and pharmacists and anyone who's giving these vaccines to follow versus what is, allowable and not considered an error if it accidentally happens. Thanks.
Thank you. Dr. Daly.
Yeah, thanks so much. I have two comments and then a question, and I'll try to keep them brief. The first comment is one of thanks. I want to sort of reiterate some of the thanks that have been offered so far today, but wanted to thank Dr. Fink and his team for his leadership and for their reviews, because I think this isn't an overstatement to say that you've been asked to do a year's worth of work in several weeks, and you've done that without skipping any steps. And I just want to thank you for that. And then a thanks to Dr. Oliver and her team. Again, I don't think it's an overstatement to say you've been asked to do a year's worth of work in several weeks, and again, did it, without skipping any steps and then bring all this data for us. So again, a thanks to Dr. Fink and to Dr. Oliver. The second is a comment about collaboration. It strikes me that we need to simplify this, and it's really going to require collaboration between manufacturers, the FDA, and the CDC. And so I just want to push towards that because I'm also concerned about vaccine administration errors. And then there's a third question, the third thing that I have to say that's really a question, which is about intervals. And for other vaccines, we have these concepts about a minimum interval, but then a recommended interval. And then there's also sort of something like an accelerated schedule. And so my question is, I know we're not there yet, but if more data comes out about the benefits of 8 weeks between a first and second dose of an mRNA vaccine, then I understand that there are some regulatory steps that need to happen, and maybe it happens at the time of BLA. But if Dr. Oliver and or Dr. Fink could address the idea about, is there a time where we could have a recommended interval of 8 weeks between first and second dose should the data support that? Thank you.
Yeah, this is Dr. Oliver. I'll say something and then maybe see if Dr. Fink can weigh in as well from FDA standpoint. This is important though, and I do wanted to highlight this before we go to any vote. The vote will be at the authorized schedule. So it'll be, the authorized dose at the authorized interval. But the reason we've highlighted, and again, going back to what I said before, that we find ourselves in a really unique situation with the EUAs and the legal ramifications and everything that is tied to that. However, we do have the ability, the 8-week interval is in the interim clinical considerations. We've stressed it here. We'll continue to stress it when we do education around this. It's been incorporated into the amazing schedules that Dr. Hall has put together. We hope over time we're in a less kind of constrained environment with the provider agreement and the PrEP Act and the EUAs. And so I don't know if Dr. Fink can comment on whether that's kind of exactly when it moves to BLA or if it's a continued discussion time point when we have a little bit more flexibility than what we have now. But we'll be voting on the authorized interval with the acknowledgement that there will be the information on the extended interval in the interim clinical considerations and in educational materials. Thanks.
Hey, this is Jordan. Thanks. I'll just echo what Dr. Oliver said about how challenging it's been to navigate all of the various legal considerations around EUAs and the PrEP Act and the provider agreement when trying to address these various clinical scenarios. I think, in considering whether and how to update FDA labeling to include a different interval, it is all tied together. And so what we would say for an EUA would also have to be reflected in the approved labeling for product that's available under BLA. And so that's one of the challenges and difficulties. It's also somewhat of a paradoxical situation in that the level of evidence that would be typically required to support a revision to labeling of a BLA product is higher than what might be necessary to support a change to an EUA. And yet it's, for the EUA products that, really there's the biggest desire to have this changed. Ultimately, though, what we would have to do would be to work with the manufacturers to consider available data and to consider whether those data would meet our evidentiary standard for a labeling change. And I think we could do that at the BLA stage, but again, you get to the paradox where at the BLA stage, there's probably more flexibility in what ACIP is able to do with regard to off-label recommendations. Over.
Thank you. Dr. O'Leary.
Yeah, thanks, Dr. Lee. I just want to comment actually on this slide that is up right now. And just speaking as a colorblind person myself, I will say that these first three columns here are kind of a nightmare. But, if you look at it, the 6 month through 5-year-old is a 0.25 ml dose. The 6 through 11-year-old is a 0.5 ml dose. And it would really simplify the lives of those stocking the vaccines to simply have the one product rather than having to stock two different products for these two different age groups, because the dose essentially would be the same for the 6 through 11-year-olds, and I think could potentially really decrease administration errors and also simplify stocking from the standpoint of general pediatricians and family docs and pharmacists, et cetera. So I'm not sure why we need to have that booster potential, third column there in this whole setup. I'm not sure why that decision was made, but I think it would really simplify things not to have that extra product in there. And I'll stop there.
Thank you. Just a quick request. I think I have two more hands raised. If there are any additional or new issues you'd like to raise, that would be terrific. I think you've heard, or everyone has heard, our plea for simplicity and streamlining implementation. So, perhaps you can count on all of us to be able to contribute as needed. But we'll ask for some quick comments and questions, and I want to make sure we get to the vote and the question at hand. So, Dr. Sanchez.
Thank you, Dr. Lee. I just wanted to urge and just as a shout out to the immunocompromised individuals, because we really need clarity with respect to Moderna dosing with booster dosing in the severely immunocompromised individuals, because I remain concerned that there may be switch over to Pfizer to provide further doses. And so I think we really need a timely guidance on further dosing of the Moderna vaccine in the immunocompromised children. Thanks.
Thank you, Dr. Long.
Oh, sorry. Do you mind if I just want to
Go
clarify that for the Moderna, and Dr. Hall can correct me if I'm wrong, for the Moderna product, for 6 months through 17, so the entire pediatric age group, we will have a third dose in the primary series as a part of the CDC recommendations. So there are not yet boosters recommended, and as Dr. Fink said, we expect that may change over time. But I do just want to clarify that it is a 3-dose primary series as it is for all the other age groups for Moderna. So we will take care of that. We did it with the 6 months through 5 years, and we will do it with 6 through 17 when the CDC, if voted, when this becomes a CDC recommendation, we can take care of that. So anyway, there will be that extra dose for Moderna for immunocompromised. Thanks.
Thank you. Dr. Long?
Yes, it is a separate subject. Are you planning, Dr. Lee, to put up the language for the recommendation?
I appreciate you are encouraging us in that direction, Dr. Long. So, Dr. Oliver, can you put that up?
Thanks.
Dr. Oliver, would you like to read it?
Yes, so we'll have 2 separate votes. The first one is a 2-dose Moderna COVID-19 vaccine series at 50 micrograms is recommended for children ages 6 through 11 years under the EUA issued by FDA. The next slide. We have a 2-dose Moderna COVID-19 vaccine series at 100 micrograms is recommended for adolescents ages 12 through 17 years under the EUA issued by FDA. Thanks.
Thank you.
So now here's my question. I know we did not study this vaccine compared with Pfizer head-to-head to be able to say the intervention favors both. And I understand, everybody understands why. But the fact of the matter is we have out there currently a recommendation for the Pfizer vaccine in these age groups. So because there has been a lot of presentation and the world would expect us to weigh in on whether this possible increase in myocarditis dissuades us from considering these vaccines differently. And I think we need to say somewhere that this offers the option and there is not a preference. It's an unusual situation to have had the one that was a research vaccine approved during the research for this vaccine. So we do have a standard right now. We wouldn't let anybody any longer look at a placebo. So I think we need to say something about lack of preference somewhere. I don't know that it has to be, or maybe we should say on these, this vaccine is an option for a vaccination for coronavirus.
Thank you, Dr. Long. I'm going to perhaps jump in and then ask either Dr. Daly, Oliver, or Wharton if they want to chime in, but just I want to focus in on the vote language. I understand the recognition that there is no preference, which I think is really important. To me, I think that goes into the statement, but we don't usually actually say we don't have a preference in a vote, with the exception being yesterday, which was a sort of a different situation, but I don't want us to get into the pattern of incorporating that into every single vote with multiple vaccine products. So that would be my preference, but if anyone else wants to weigh in, please do.
Yes, Dr. Lee, this is Dr. Wharton. I agree. We had several votes yesterday where where the committee recommended products as acceptable alternatives to already recommended products, and I think this is analogous to what the committee did yesterday with a couple of other vaccines.
But would ask Dr. Oliver and team if they can just make sure in the full statement that that is reflected, because I think that's probably, we want to make sure your point is made, Dr. Long. Dr. Freihofer, is your hand raised from before? I wasn't sure. Okay, thank you. I don't see any additional hands raised. Is there any additional comments or discussion that is needed for the vote language? And if there are no additional comments, I'll ask if any of my colleagues would like to make a motion. Dr. Paling.
Yes, this is Kathy Paling. I would like to make a motion to accept both recommendations as they are written. Thank you.
Dr. Wharton, can I do that? Do I need to take one at a time? I think I need to take one at a time. Let me take this one first. So Dr. Paling, we'll log you in as the first primary motion for the first vote, just to avoid confusion. Ms. Bata? You second? Okay, terrific. Thank you. So it's been moved and seconded that we adopt the recommendation language on this slide, since it is one of the votes. Can we go to the next slide, please? And do any of my voting members wish to make a motion on this second vote? Dr. Cotton?
I make a motion that we vote on this second recommendation.
Thank you, Dr. Cotton. Do I have a second? Dr. Sanchez?
Yes, I'll second that. And I just have a comment. It's a 2-dose for these individuals, but do we have to say anything for the 3-dose for the immunocompromised? Or will that be just in the clinical considerations?
Dr. Oliver?
Yeah, no, thanks. I appreciate the chance to clarify again. So we'll ask you guys to vote on this, and then we will take care of it as we did over the weekend when it was for 6 months through 5 years. We'll take care of it from a CDC recommendation. So it will be an official recommendation, but you guys have voted kind of broadly for that additional dose in immunocompromised, and we've kind of let that stand as ACIP's endorsement, and we've made it a formal CDC recommendation when we transfer these over. So we will absolutely have that in there. We just haven't specifically asked that you vote on that, but thanks.
Thank you. So it's been moved and seconded that we adopt the recommendation for this vote for the 12 to 17-year-old population on this slide. And so with that, we will return to the vote after public comment, but we do have a public comment session. Thank you very much to our members and to our liaisons. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important each speaker limits his, her, or their remarks to 3 minutes. We have a timer on display on the screen so you know how much time you have left. And as a general reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed during our 2-day meeting. We want to thank our speakers again, and we look forward to your comments. Our first public comment speaker is Mr. Jonathan Cooey.
Hello, can you hear me?
We can. Please go ahead.
Thank you. My name is Jonathan Cooey, and I have no conflicts of interest. The ethical principle of informed consent has been effectively ignored for the duration of the pandemic. The FDA and the CDC long ago failed to meet their responsibility to ensure informed consent in those healthy adults who have been already transfected, most egregiously in the healthy college students and teens for whom there was never an emergency. The CDC and FDA failed again just days ago to provide the opportunity for informed consent, this time for parents of children under 5, when recommending transfection as safe and effective. After nearly 2 years of calling transfection by lipid nanoparticle an investigative vaccine, you have failed to provide informed consent by pushing a false equivalence between transfection and traditional live attenuated and recombinant vaccines. You have failed to inform the public that transfection, the expression of a viral protein via injection of synthetic RNA, is a highly variable and tissue-dependent process that we are unsure can provoke meaningful immune memory, the goal of any vaccination. You have failed to notify the public of the potential for autoimmunity while also failing to look for this known downside of this technique. The FDA have no data to support recommending transfection for any healthy human in 2022. After more than 2 years, you have failed to inform the public that you know the studies upon which these recommendations are based are woefully underpowered. In place of informed consent, you have pushed the vague concepts of safe and effective until they were devoid of meaning. The studies used to specifically recommend transfection to the under 5 age group are statistical jokes without clinically meaningful endpoints. You know immunobridging to non-inferiority is useless. Do your job. Of course, the CDC, NIH, and NIAID also failed to inform the public that they knew late in 2019 that the virus had already several key molecular aspects that indicated both its origin and the many known countermeasures that would be expected to work. Instead, they said they knew nothing, they could see nothing unusual, and that our immune systems were equally vulnerable, and you ran with it. Data from your own presentations demonstrate the vast majority of kids have been infected, a primary counterindication for the administration of any vaccine before 2020. You are pushing products under the guise of a regulatory framework that we know by your actions is pro forma only. You failed to inform the public that you know from studying influenza and other viruses that the developing immune system is an impossibly complicated process that involves imprinting mechanisms that cannot be reversed. The catalog of molecular immune memories that protects us for a lifetime is formed through the countless exposures of pathogens in our childhood, and you have failed to inform the public that you know that transfection to a 2020 viral coat protein cannot be useful in augmenting this process. You know it will not meaningfully protect these children because there is a planet worth of data informing you of this. It's biology. Please get some and then do your job.
We will move on. Thank you for your comment. We'll move on to the next public comment speaker, Mrs. Barbara Lepke. Mrs. Lepke, if you're on, we cannot hear you. I'm going to pause and suggest we try and see what we can do with the audio issues. And why don't we come back to Mrs. Lepke and we'll go to Dr. David Wiseman.
Hello.
There you go. Please go ahead.
Yeah, I'm sorry. I wasn't expecting that so quickly. Thank you. Thank you, Dr. Lee. CDC's website asserts that FDA has determined that COVID vaccines are safe and effective for everyone 6 months and older. It certainly has not. FDA guidance describes the EUA standard as may be effective, lower than the conventional effectiveness standard. For EUA safety, FDA must determine that maybe benefits outweigh the risk. FDA has published its methodology in the journal Vaccine and in the VRBPAC meeting for 5 to 11-year-old doses. Why has this analysis been absent in recent VRBPAC deliberations? Well, according to FDA's Dr. Fink, Pfizer's under 5 efficacy estimates are preliminary, imprecise, and potentially unstable. If FDA does not know the vaccine's maybe effectiveness, how can it calculate benefit over risk? The green light to vaccinate millions of children based on 3 Pfizer vaccines and 7 placebo events is stunningly absurd and impugns all related decisions about Moderna. These data also show negative VE for Pfizer in some scenarios, also shown in waning by CDC. Moderna provide no waning data, but surely must have it, as they will be reportedly presenting both booster data next week. In a paper by Dr. Walensky and colleagues, warnings that waning natural immunity present a risk to vulnerable populations apply equally to vaccination. Moderna's 2-dose data for 6 and above were pre-Omicron, a problem FDA invoked to deny fluvoxamine's EUA. Why not here? FDA's Dr. Fink tells us that immunobridging may not be scientifically established. Worse still, it targets Wuhan. Pfizer and Moderna's few Omicron assays are unvalidated, with data FDA say they have not verified. Claims of clinical relevance are ridiculed by CDC's analysis Friday of two Pfizer doses showing significant VE for toddlers with failed immunobridging, but the reverse for infants. VSD's myocarditis rates are 6 times higher in 5 to 11-year-olds than in theirs. Dr. Long appropriately notes that myocarditis booster rates match or exceed the primary series rate. A new FOI disclosure reveals that CDC has not, per theirs SOP, conducted PRR safety analysis, which we have provided to FDA and CDC several times. Confusing intervals, labels, and guidance will surely add to the 1,300 plus children's dose errors noted by CDC. VRBPAC's Dr. Pointnoy asked Pfizer which cells produce spike, how much they produce, and for how long. Pfizer dismissed this question as academic. It is certainly not. Understanding these basic questions is vital to understanding safety. Moderna's answer to Dr. Sanchez's Similar question today was that the spike persists for less than a week. A Stanford study in Cell showed persistence of vaccine message and antigen for at least 60 days. Unless FDA, Moderna, CDC, and Pfizer can provide this information, parents have every reason to avoid injecting their children with these maybe effective gene therapies. Thank you very much.
Thank you for your comment. Next, we have Mrs. Melissa Chios.
Good afternoon. Melissa Chios here to speak on Moderna COVID-19 shot votes for kids aged 6 to 17 years. I'm hoping that prior to the vote, Dr. Sarah Oliver, who's up next, can address the many dangerous data points emerging over which tenured medical professionals all over the world are sounding the alarm, some of whom are the most published in their field. Let me be clear. Children's death rate from COVID-19 is statistically zero, with a survival rate of 99.98%. Dr. Eric Rubin, CDC Advisory Committee member, has acknowledged, and I quote, "We're never going to learn about how safe the vaccine is until we start giving it. That's the way it goes," end quote. If our children have a statistical risk of zero from dying from COVID, why on earth are we to assume a risk with a vaccine for which we have no real risk profile? These trials will not be concluded until 2024, meaning our children are the experiments. During Tuesday's VRBPAC meeting, Dr. Ruth Link-Gillies from CDC admitted that the COVID-19 shots have negative efficacy. One of the already known and acknowledged COVID-19 shot risks include myocarditis. Even Dr. Tom Shirobakuro here has previously acknowledged that these shots cause myocarditis, citing his own slides and those of John Sturu and Nicola Klein. Why are so many healthy children and young adults developing myocarditis? Why are so many athletes dropping on the ball field? And why is this panel making recommendations in favor of a product you have acknowledged to cause severe adverse reactions? Why is no one here discussing the serious issue of antibody-dependent enhancement and prion disease and cancer? Why are 236 records of the 270 pregnant women disappeared from the Pfizer trial? And why did 28 of those 34 women whose records remained lose their babies? At Rambam Hospital in Haifa, Israel, reports indicate 34% more spontaneous abortions and stillbirths occurred in vaccinated women compared to those unvaccinated. This presents a statistically significant increase in fetal demise. Why is this all being ignored? Various studies have now confirmed menstrual dysregulation in women who've had the COVID-19 shot, as well as heavy spike protein accumulation in the ovaries. Studies have also found that these shots affect male fertility. Among semen donors, studies show that these vaccinated for COVID-19 have impaired semen concentration and reduced total motile counts. How can anyone ignore these signals of infertility? And how can you have no answers or a plan for those who plan to procreate in the future? How is it not gross negligence for this panel to continually ignore blatant cries of tens of thousands of researchers and doctors across the globe while these alarming signals remain unaddressed? Do not turn the other way and vote for another unproven shot while these alarming data points exist. Doctors, scientists, and parents are watching, and we deserve answers. I don't know how any of the panel can sleep at night, knowing that there are so many dangerous signals that are being blatantly ignored. And it is unconscionable to continue to keep voting for additional vaccines. Has anyone looked at the VAERS reports? By the way, 85% of those VAERS reports are reported by healthcare professionals, not the general public.
Thank you for your comment. Next, I believe we have Mrs. Barbara Loki on the line. I just want to confirm. Mrs. Loki, are you able to unmute? I think I can see you on the line, but we still can't hear you.
This says that I'm unmuted.
Okay. Oh, good. We can hear you now. Please go ahead.
Okay. Thank you. My name is Barbara Lepke, and I have no conflicts of interest. Regarding the presentation about the HPV vaccine yesterday, it is concerning that the word estimated was used over and over and over. Do we not have any real data? There was no mention about the adverse events that are experienced by some here, the POTS, the infertility, the gastroparesis, and the other neurological problems. And frankly, I'm really appalled that no one in the committee even batted an eye about the studies used for yesterday's HPV presentation, that they were all conducted in third world communities. The reference to the India trials was stopped by their government and was quickly brushed over and not discussed. All there was just a general applause for the vaccine and what it's done, but no real data. On to the COVID vaccine. The use of the phrase putting the incidence in context is definitely bypassing the first do no harm ethics, which used to be part of medicine. Harm of children is now acceptable for the greater good. If we know that myocarditis can be caused by the vaccine, why is there only one injury that's been determined to be compensable by the countermeasures program? There's no help for the injured. Today, finally, Dr. Sima Bakura had admitted that there are many experiencing injury. He's admitted that they don't know the mechanism or how to help them. Continuing to put these harmful vaccines onto the schedule when you know people are being injured, these injuries and the lives affected are on your hands. There's no other answer. With the official acknowledgement today, you can't say you don't know about them, but there will already been 2,176,799 reports filed in VAERS for the COVID vaccine. Last week, the committee said that putting the COVID vaccine on the schedule just means that parents who want the vaccine for their children can get it. However, we all know that if a vaccine is recommended for children by the CDC, it will be made mandatory for daycare and school. As several states only have a medical exemption, and doctors that give medical exemptions in those states are having their medical license attacked for doing so, there will be no choice allowed for many parents. The decision took away choice. Regarding the allowance of the use of the 10-dose vial for babies and toddlers, it's just a disaster waiting to happen. As quoted from a renowned statistician, 10-dose vials are terrible because administration errors go up and because it's impossible to guarantee consistency across doses. Different cap colors have not stopped errors. Currently, there are 21,012 dosage errors in VAERS. President Biden on June 10th stated that parents can make appointments.
Thank you for your comment. Your time has expired. Thank you. We'll move on to the next public comment speaker, Thayer Phillips.
Thank you for having me. I'm Thayer Phillips of Senior Speak Out. I want to start by thanking this committee for your continued diligence toward ensuring vaccines are available for Americans throughout our lifespan. As many of us are parents, grandparents, aunts, and uncles, we were particularly grateful for the recent approval of the vaccines for the youngest children. As you know, older Americans can benefit greatly from vaccines, as we are most likely to be managing chronic conditions and a weakening immune system. As we learned early on in the pandemic, COVID-19 posed a greater threat to older Americans than in any other age group. In fact, grim statistics recently released by the Associated Press showed that 3 out of 4 COVID deaths were older Americans, which further illustrated this very real threat. Despite entering into year 3 of this pandemic, our generation has not lost our resolve in fighting back against this virus and has embraced the vaccine more than any other age group, with 95% of Americans over 65 having received at least 1 dose. With that in mind, it is particularly important to those of us who serve older Americans to continue our work to keep their vaccination rates high, and for COVID, added booster doses if necessary. Now that we as a country are able to vaccinate to prevent COVID from the very young to the very old, we should remain steadfast in our efforts to keep COVID boosters at the front of older Americans' minds. To that end, the work of ACIP will be critically important in the months to come, so that groups like ours can help encourage our fellow Americans to remain up to date on boosters, as well as being vaccinated for other respiratory illnesses like the flu and pneumonia. As you know, vaccination rates pre-pandemic were not ideal. The pandemic squashed those routine vaccination numbers even further. COVID vaccinations were somewhat of a bright spot, with older Americans lining up. Let's build on that. Let's continue to work together to benefit this important community and ensure that they are informed and, most importantly, protected against COVID-19 and other preventable diseases. Thank you.
Thank you for your comment. Our next public comment speaker is Mr. Daniel Grenier. Mr. Grenier?
Okay, can you hear me?
Yes, please go ahead.
The authorization of this experimental mRNA gene therapy will forever be a dark moment in human history, where kids became sacrificial lambs for pharmaceutical profits. Don't take my word for it. Read the BioNTech SEC filing, where it says our revenue heavily depends on COVID-19 vaccine sales. The CDC frequently pairs the benefits outweigh the risk. Is that so? The only benefit I can see is 50 billion expected sales for Pfizer and Moderna in 2022. And the only risk I see are 1,291 side effects from Pfizer's documents that the company, in collusion with the FDA, attempted to hide from us for 75 years. These are the side effects that this advisory panel has placed babies as young as 6 months old at risk of. And since these shots do not prevent transmission, they are in fact useless and make the public more at risk of COVID. In the words of virologist Geert Van Bosch, scientifically, there is no rationale whatsoever to vaccinate children. There is no added value, only major concerns and major risk, and it is criminal. It is especially criminal since children have a 99.995% recovery rate, and over 75% of American children have already built superior natural immunity. In short, this agency has faked an emergency for children to gain emergency use authorization to shield itself and the pharmaceutical companies from liability for serious and permanent injuries and deaths. The 1986 National Childhood Vaccine Injury Act has given rise to a criminal enterprise that allows pharmaceutical companies to kill and maim with their shots. It's especially disturbing that the United States of America is the only country in the world conducting this medical experiment on children under 5. Countries like Sweden and Finland, for instance, have banned the shots from Moderna for under 30 years of age and other younger populations, citing the risk of heart inflammation that the CDC itself recognizes. But you knew the safety signals. It's explicitly stated in the 1.3 million adverse events in the VAERS database, including 48,500 in children as of May 20th this year. In summary, there is absolutely zero health benefits from these mRNA gene therapies. Preliminary data from the three shots show that they cannot even meet a 50% efficacy to meet EUA approval. In short, I urge every parent to keep these poisonous shots away from your children and do not sacrifice them, the altar of science, where the S is a $sign. Thank you.
Thank you for your comment. And I want to thank all of our public comment speakers today, and also our public comments that are provided via the written docket. We will now move on to our vote section of the meeting. Thank you so much for putting that up. We have two motions on the table. We'll first discuss this motion for the ACIP vote. A 2-dose Moderna COVID-19 vaccine series, 15 micrograms, is recommended for children ages 6 to 11 years under the EUA issued by FDA. Are there any issues or questions people want to raise at the moment? And while you're thinking, I'll ask committee members to please turn on your video. Thank you to those who've already organized and done that. I don't see any hands raised. So we will proceed to a vote. And as a reminder, please state your name, whether you have any conflicts of interest, and then your vote for the vote on this current slide. I'm going to go easy today, and we'll go in alphabetical order, starting with Dr. Alt.
Alt, no conflicts, yes.
Thank you. Ms. Bata.
Lynn Bata, no conflicts, yes.
Thank you. Dr. Bell. I'm looking for, I see Dr. Bell, but I can't hear her. So we'll come back to Dr. Bell. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Thank you. Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you. Dr. Cotton.
Camille Cotton, no conflicts, yes.
Thank you. Dr. Lair.
Jamie Lair, no conflicts, yes.
Thank you. I realize we're out of alphabetical order, Dr. Lair. I'm going to go next. Sorry for that. Grace Lee, no conflicts, yes. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Ms. McNally.
Veronica McNally, no conflicts, yes.
Thank you. Dr. Paling.
This is Kathy Paling, no conflicts, yes. And I apologize, I can't get my camera to work.
That's okay. Thank you for joining. Dr. Sanchez.
Sanchez, no conflict, yes.
Thank you. Dr. Talbot.
Talbot, no conflict, yes.
Thank you. And Dr. Bell.
Bell, no conflicts, yes.
Thank you. Okay. So Dr. Wharton, I believe we have 15 yeses and 0 nos.
That is what I got as well. Thank you.
Thank you. We'll move on to vote number 2. And we will go in reverse order. So first, are there any objections to proceeding with the vote? I see no hands raised, so we'll start with Dr. Talbot.
Dr. Talbot, no conflicts, yes.
Thank you. Dr. Sanchez?
Sanchez, no conflict, yes.
Thank you. Dr. Paling?
Paling, no conflict, yes.
Thank you. Ms. McNally?
McNally, no conflicts, yes.
Thank you. Dr. Long?
All the way from Paling to Long. My name is Sarah Long, no conflict, yes.
Dr. Lair?
Jamie Lair, no conflicts, yes.
Thank you. Lee, no conflicts, yes. Dr. Cotton?
Camille Cotton, no conflicts, yes.
Thank you. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Dr. Sineas?
Sybil Sineas, no conflicts, yes.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Bell?
Bell, no conflicts, yes.
Thank you. Ms. Bata?
Bata, no conflicts, yes.
Thank you. Dr. Alt?
Alt, no conflicts, yes.
Thank you. So Dr. Wharton, I have a tally of 15 yeses and 0 nos, and this vote also passes.
Thank you, Dr. Lee.
Okay, terrific. Thank you very much, everyone, for your votes today and for your patience. I want to just acknowledge and thank my colleagues for asking all of the questions that you did today. I know our discussion went long, and so with permission from the Director of NCIRD, we are going to alter our schedule for the remainder of the afternoon. So I'm promising you a break right now. And then after the break, we'll come back. We are actually going to move our meningococcal vaccine session and our chikungunya vaccine session to a future meeting so that we can have the remainder of the afternoon to discuss RSV and monkeypox. So why don't we take, if this sounds okay to everyone, a whole 15-minute break so that you can maybe get some lunch or a snack. And we'll be back at, I can't add 15, so 40, let's say 55 minutes after the hour. You get 16 minutes. Okay, 55 minutes after the hour. Thank you.